Okay, John, Maria, Jason, Christina, T. All. Okay, Sophia, I got. Okay, everybody's here. Awesome. So far, so good. Let me record this. Bear with me, everyone. You know I'm not the greatest in computers. Now, this one I can record to the cloud because this is my personal one.
Recording in progress.
Okay, it's being recorded as we speak. Good evening, everyone. Frank Nuki here, one of the CICs, in LaGuardia Community College. We're going to be going over patient assessment, and hopefully after we go over this whole PowerPoint presentation, I won't be going through every single thing here. I'm going to skip a lot of stuff because you should have already got the lecture on this, read your textbook on this. I know it's a lot and know the difference. And you probably even got skills on this, on patient assessment, probably medical and trauma. Most of the time they start with the trauma. Are they still doing that?
It did kind of both.
Yeah, we did
Okay, a
medical
little bit
and
of
trauma
both.
on
Yeah, it
Thursday.
depends how you do it. It depends the class, but that's okay. As long as you're understanding the material, we're going to focus on certain things. I'm going to say, make sure you know this and highlight this in your book. This is what I see a lot. You'll see it on test questions and maybe in class, or you definitely see on state. Okay, that's important. MOI, NOI, oh yeah, that's for sure, John. All the time. Mechanism of injury and nature of illness. You definitely got to know those things. Is the sign-in sheet posted yet? No, I'm doing it right now, Maria. So let me send it out so all of you can sign in. Sign in. Okay, I just sent it out right now. I'll leave it up for a few minutes. Make sure you sign in. Make sure it has your name, first name, last name, because I definitely have to send this to your senior instructors and also to the director. Okay, so make sure on that. Okay. While that's doing that, I am going to begin. Okay, you know how it always starts. It starts with that National EMS Educational Standards and Competencies. You're going to see it talks about all the different parts of the scene, size of primary assessment, and so forth that you're going to go through. You will get this PSC at the end, the skill on this. These two stations are called medical and trauma. I think station 1 is medical, station 2 is trauma. You would get different types of patients. On medical, they normally, this is me, what I know, they normally would give you, let's say, cardiac or respiratory or maybe altered mental status and anaphylaxis. Those are the 4 they normally give that they could give you. Can they give you all 8 different sections? Yes. What I mean, cardiac, respiratory, altered mental status, anaphylaxis, OBGYN, behavioral, and so forth. They could do that if they want to, because you need to know all these different questions you need to ask these type of patients. I sent you a handout of that. It's called Focus History. There's like 9 different boxes. And I think the last one on the right-hand corner is to do with the abdomen, or what questions you could also ask. I remember always on the 3, it's OPQRSTI that you could ask for more information besides that sample. Okay, and that's good for cardiac, for respiratory, and abdomen. Just know that for the future when you look at that. Now, each one of these sections here we're going to go to. You're going to see it's going to talk about scene safety, about hazards and violence and everything else that you spoke about probably with your instructor and what you read. A lot of the stuff, this is what we normally do, and this is how you get tested. You're going to be going to the scene. They're going to give you a scenario, and it's the first thing you're going to be saying. BSI, scene is safe, number of patients, additional resources. Is this a MOI? NOI, consider C-spine. That's one way of being taught. Another way of being taught, they use this LISA mnemonic, like the fire department use and other places use also. LISA stands for life threats, impression, spinal, and then APU. That's a LISA mnemonic, which covers spinal in this section of scene safety, because there's 6 things you must say, verbalize when you first approach the scene. Whatever scenario they're going to give you, medical or trauma. Nothing changes within the first 90 seconds. And then you get into your primary assessment, which you're going to get into later. Primary, if you do it in a certain order, is general impression, then the mental status, which you use your APU, that's your AVPU mnemonic, and then you try to see if there's any life threats, and you get a chief complaint. And then in order, you do A, B, C, D, just like that. I'm telling you this right now, A, B, C, D you cannot deviate from it. You cannot do airway, then go to circulation, then go to breathing. You will fail, especially in skills at the end, okay? So make sure when you get taught physically those skills, you do airway, breathing, circulation, and decision-making. Everything else underneath that in medical or trauma, the state always starts like with so-called the vital signs, and then they have the sample or ample, and then they have the OPQRSTI and so forth, and then your body system. And then, of course, I think it's your state of impression again, your transport, and then you have that reassessment. And this is at the end of the skill sheet. I will show you that skill sheet again here so you know exactly what I'm talking about and why I'm going in order, because that's how you're going to be tested. What I do, question-wise, scene safety, I will ask you certain things. I would say all the following part of scene safety except. If you always verbalize in the main 6, you can never get that test question wrong. But you need to know what you do for each section, okay? And we'll address that as we go. So this is part of the scene safety that you see here. There's another part. We said this. Additional resources, standard precautions to do with the CDC. What is that? You wear your gloves, your final gloves, right? Or your latex gloves. You put on the goggles, and you have a face mask, which is an N95. If you notice, what are you protecting really? Your mucous membranes, right? Eyes, mucous membranes, to do with your conjunctiva, inside the nose and inside the mouth, mucous membranes. Test question I will give, all part of the mucous membranes except, and it would be the lips, because the book talks about 5 things to do with mucous membranes. And why? Because these areas are always moist, okay? Your conjunctiva, inside your nose, inside your mouth, and I'm not trying to be nasty, your anus and your vagina, okay? Those are always moist. Everywhere on your skin, nothing. So the answer will probably be the lips when you see a test question like that to do with mucous membranes, okay? So let's continue here. You notice you have your primary assessment. Your main goal in the primary assessment here, you must know that. You see where it says identify life threats? That's always a test question. So you need to know you identify life threats first, and life threats supersede A, B, C, D. So a patient had a spurting carotid artery spurting like this, okay? You're not going to waste your time airway, breathing, and circulation. You're going to take care of that life threat first, and then do your A, B, C, D. Remember that. Life threats supersede A, B, C, D. That's always a test question. What's your main goal in the primary assessment? To identify and treat life threats accordingly. And you're going to see when they show other ones here. Okay? And you notice here, look what's here. I said it before, general impression, right? A level of consciousness, that's to do with your APU. That's the AVP of you. Alert and oriented times 3 or times 4 when you ask the questions. Verbal response, painful response, and then unresponsiveness. I'm telling you this right now. At the end, when they're going to test you, most likely you're going to get medical that they want you to ask a lot of questions because it's 80% questions. So they want to give you a conscious patient to see how you're going to get all of that and gather that information from that patient. On trauma, I'm telling you this right now, if it was me back in that class in Queens, I would give you trauma, and I told the instructors, give them one of these 5 scenarios. And I always love to give a gunshot wound, a stabbing, an assault, a person hit by a car called pedestrian struck, and the 5th one is a fall. It could be from a building or a ladder. Those are the main 5 I like to tell instructors, skip. So each student that comes in, give them a different one. And let's say I have a number from 1 to 5. So Kelly could get number 1, and Lewis could get number 2, and so forth to do with that trauma. But that trauma patient, majority of the times, I'm going to say make sure they stay unconscious. Why? Because I want to see them physically do that hands-on. That's when you get to that decap BTLS, and you're going to see what I'm talking about. Because a lot of you get confused with medical and trauma right after your decision making. You're like, okay, what do I do next? And you confuse something and you put it there when you're not supposed to yet. Okay, trauma is trauma, mechanism of injury. So you'll do probably in a secondary, try to get a sample history, and then there's a head to toe, decap BTLS, okay? And that's a lot of points. And you're going to see when I show you the skill sheet again, why I want you to always separate these two when you get skill tested or verbally when they're writing like a scenario base. So my general impression, short and sweet. 25-year-old male hit by a car lying supine, or 35-year-old female sitting upright on a chair complaining of difficulty breathing. Whatever the scenario is, I know it is. I always give short and sweet. The book talks about giving a race. I don't do that. That's just me. Okay? I don't go 35-year-old Puerto Rican sitting upright. I don't do that. I don't even say Hispanic. I say, 35-year-old male sitting upright in a seat. It's just me. I don't think at that time, like the book does, that you have to give their race. It's just me. Okay? But short and sweet on this. So remember this. So general impression, that level of consciousness, which is the APU. Okay? Identify any life threats, chief complaint, and then ABCD in order. That is New York State sheet. Assessment of vital functions, you can look at it, not vital signs. Vital signs are done after the ABCD, okay? The first 90 seconds, I could tell what's wrong with you within the first 90 seconds I go on scene, maybe even less than that, because I'm experienced and I've been doing this over 30-something years. Okay, that's a difference. But when you're new to this, you got to follow order. The state sheet wants you to follow order. Okay, you continue, begin interventions, integrate treatment and procedures needed to preserve life. Do you just follow this? History taken, that is your sample. Everything here we're going to talk about, you need to know sample. They probably taught you in skills already how to do sample, and they probably taught you how to do vital signs, and they gave you 5 vital signs to do, more or less, and then they called the pulse-ox the 6th vital sign, technically, right? And if did you do general pharmacology yet? No?
Yeah.
Have fun in that. When you can do the pharmacology, that's a nice skill. When they actually going to talk about all the drugs that you guys are going to utilize once you carry on the ambulance and once you don't. There should be a total about 7 different drugs that you carry on the ambulance, okay? And then the other ones when you assist with the administration of it, like the MDI and the nitroglycerin that the patient carries. When we get to that, we'll talk about that in the future. Okay, so this is your history taken. Think of your sample. This happens in medical and in trauma. You notice here, you're going to get to do with vital signs. You are going to do a head to toe when it comes to trauma. But when it comes to medical, in the secondary, you're going to do this one prior, which is your sample. And then right after that, it's more questions. So if you did vital signs first, according to the state, and then you did the sample, then you do the OPQRSTI. That's all medical. So I'll say it again. Seeing size up, primary assessment. You did everything in primary. You did your general impression. You did your APU, which is your mental status, okay? You try to get a chief complaint and see any parent life threats. And in order, you did A, B, C, D, and now you made your decision, high priority. In the state sheet, in medical, they mostly start with vital signs first, then the sample, and then the OPQRSTI, okay? Technically, that does not have to be done in order, okay? But if you're a senior instructor, which is Yadiro and Irene says they want it in order, then you do it in order. You go according to the state sheet. And the state sheet, just to give you an example so you know, and you don't freak out what Nuki's talking about, looks like this. That is your medical. So they'll read this to you. Okay, this is when you get tested at the end. They're going to read all this to you, and then they're going to give you a scenario. They're going to say you have two imaginary EMTs with you and so forth. You're going to have a patient sitting down on a chair, whatever they're doing in class, and then you have to do this. So the first thing you're going to be doing after they read you that and they give you the scenario, this is what you have to do in order. So this is you. PSI, seen is safe, number of patients, additional resources. This is an NOI, nature of illness, because you know you're going into a medical, I would consider C-spine. So you did all this in order, okay? This two criticals, you must do it. If you don't say these two things, okay, and wear your gloves, you failed. And they won't even tell you that, okay? They'll let you do the whole skill until the end. Now, look what's in order here. General impression, determine response, your APU, life threats, and chief complaint. And in order, criticals, look at that. A, B, C, D. All criticals have to be in order. So if you know these mnemonics or the acronyms for each one of these, if you're doing the airway first, what you do, I teach open the airway, clear the airway, maintain the airway, listen for sounds. That's me. Some people just use OCM. Some people use OCMS. I use OCMS. Open the airway, clear the airway, maintain the airway sounds. Open the airway, okay, how? Medical? Head, tilt, chin lift. I need to open the airway if the patient was unresponsive or unconscious on the floor. But if the patient's talking to me and explaining everything to me, do I need to open the airway and everything? I mentioned it to instructor, I say, my patient's talking to me, the airway is open, it's a painted airway. I'm going to continue on to breathe now. B now, excuse me. And B, what you do in breathing. You do whatever they taught you in class. They probably taught you OI pass or I pass O. Okay? Sorry about that. My apologies. I forgot to mute my phone. That's my son calling me. I was in breathing, excuse me, breathing. So OI pass. I use that mnemonic here. OI pass stands for oxygen, inspect, palpate, auscultate, stabilize, and seal. That's a mnemonic I use. Can you use it both for medical and trauma? The answer is yes. That OI pass is almost even better in trauma because of those two S at the end for stabilize and seal. You know, seal the hole of a stabbing with an occlusive dressing, things like that. Or bulky if there was fracture and flail segment, things like that. They're going to teach you that later on when you get into trauma or if you're doing both. And then that, oh, it's oxygen. How I'm going to give oxygen to this patient? You are taught 15 liters probably via non-rebreather. Okay? Oxygen. So that's done. So make sure you have that done in order. And then circulation, C. You must this. Always test questions on this. C, they always ask you this. You need to know that you see circulation. You check the voids for bleeding. Okay? It could be especially external bleeding. So think of that. Okay? You use the mnemonic VCRs. So that's the V in voids. Okay? You have the C. Now, a lot of people use it differently. They could be carotid artery. It could be CTC. Okay? Whatever, which one you were taught by your instructor, you utilize. The R is radial pulses, and the S could be skin or shock. Whichever which way the instructor taught you, that's what you go by. VCR. So my test question with you would be, all the following of this is being done in circulation except, or what other ones are being done in circulation, right? Yes. That should be already, Maria, on your WhatsApp, but I will send it again. I'll make sure that you have that in the videos. I'll forward it again. You should have access to all of this already. If you don't, Kenny, maybe I'm doing it wrong. Double check me. Make sure you have access when you log on that. John, make sure also. If not, I would definitely resend it to everybody. Okay? All I have to do is forward it to the same, and I'll highlight them all. You want to have all these things, okay? To me, it's useful to have all these things ahead of time.
We don't have it on the WhatsApp.
You don't have it on the WhatsApp?
No, we
Not
don't.
even the videos?
We have the videos.
We have the previous videos, the last two tutoring sessions.
Okay, so I will send you all this. So no, I'm not talking about the videos for the session here. I'm talking about the videos of all the skills.
No, we don't have.
Okay. I will send you all these things. I'm going to send you a bunch of stuff again and forward that's just going to help you, especially for the skills. You're gonna thank me because you're gonna say, "Oh wow, these are New York State and some other ones that companies have done from YouTube." And this was given to me years ago. Remember, this is only a guide to give you more or less what it's going to be like, how you're going to be tested, what you should know. You have to listen to your senior instructors and your skill instructors when they go through all this. Remember, everything I do for you is just a guide. If your senior instructors like Irene and Idero says differently, you go by what they say, not what Nuki says. Because I don't want to be blamed for anything. What Nuki said, no, Nuki told you to go to your senior instructor first. Okay? Make sure of that. All right. But I will make sure you get all this. So you notice how everything here is in order. And then look what they did here. They did the vital signs. Then they did the OPQ STI, and then the sample, then the body system, and then the general impression again, and verbalized intervention and reassessment. You have all 5 sections here. Okay. What I teach differently here when you get to the body systems. Let's say you do all this. You ask all the questions and you take a good set of vital signs. This is how I do it. Your instructor may teach you differently. Any one of you tell me if they went this far already to the body system that you could remember. Let's say it's respiratory, okay? What I tell the student to say when they're going to this section is respiratory, I want you to look at this. Conjunctiva in the eyes, nasal phlegm to do with the nose. Look around the lips for cyanosis or pale white lips. The neck, I want you to look for JVD and trachea deviation. For the chest area, I want you to listen for lung sounds. I want you to see if there's any medical alert tags there, cyanosis, the work of breathing, the depth of breathing, any accessory muscle use, any retractions. And then I get to the abdomen, the abdominal cavity, and I say any distension. What's wrong with the stomach in the sense of, is it soft, is it tender, things like that. And that takes care of respiratory. That takes care of this body system. If it was cardiac related, it changes slightly, and watch. If it's cardiac, I go back to the eyes. I skip the nose. I go to the lips for cyanosis or pale lips. I go to the neck and I look for JVD. You notice I didn't say the other one. Then when I get to the chest, I go for lung sounds, heart sounds, okay? See if anything of cyanosis, how their breathing is going. And then when I get to the abdominal section, the abdominal cavity, I say look for ascites, ASCITES. It's like an overinflated basketball. It's that rigid, that hard. It's because they're retaining a lot of fluid there. And then I say look at the lower extremities and look at the feet, the ankles, and the lower legs, because I want to see if they have pedal or dependent edema. They're retaining fluid. And that's to do with a heart condition. So you notice respiratory is respiratory, heart is heart. When we get further, when you're doing other lectures, we're going to get into that and you're going to understand it better. And I'll be able to help you on that. So that's everything here. I promise to send you this. Now, let's get back to where we were before. And I promise I'll send you everything. I don't want you to freak out. Breath sounds, suppressing the breath sounds, you know, and respiratory, you need to know everything to do with the sounds that's in your textbook in this chapter. Wheezing, stridor, upper airway, rhonchi, rails, crackles, fluid in the lungs. You need to know all this. They're going to give you test questions on that. You need to know what is pedal edema, what is pulmonary edema, 2 separate things. Pedal edema or dependent edema is to retaining fluid in lower extremities, okay? Pulmonary edema is fluid in the lungs. These are terms you need to know, and you need to know the sounds of pulmonary edema, fluid in the lungs. That is the rails and crackles, lower airway. And there goes your secondary. That's how they break it down to cardiovascular, neurological, muscular, and all the body regions there. We're going to go over that too. This you must know, pulse ox. I guarantee they're going to give you a test question on this. What causes a, what's the word I'm brain farting here. What causes a wrong number on the pulse ox? That's like 4 or 5 things that you know that will say, this is wrong. The machine is not working right. I'm looking at my patient. Carbon monoxide, thank you, Don. Carbon monoxide poisoning, that's one of them. Hypothermia. Need to know that, okay? Hypovolemic shock.
Would ammonia count?
Not pneumonia, no. I don't want you to put pneumonia on that, no.
Okay, so that wouldn't count.
No, not to do with an irregular number on your pulse ox. We were
Okay.
talking about the pulse ox gives you the oxygen saturation of your hemoglobin, okay, to do with your red blood cells. So the ones I'm mentioning, make sure you're writing these down when you go back to this video. Think
Okay.
of nail polish, okay? Look at your nails, ladies. Are they black? Are they navy blue? Are they red, dark in color? And also a patient being anemic, okay? So these are like 5 different things you need to know that this pulse ox machine will give you incorrect numbers. Your numbers you're supposed to see is 94 to 99. 94 to 99, not 100%, 94 to 99. Okay, remember that. Now, the BP, when we talk about the BP cuff, you need to know what these numbers represent. If I say 130 over 70, 130 is that top number called a systolic. What does that mean? Well, that means the ventricles are contracting, especially that left ventricle. If I say, what does the 70 represent? That's the diastolic. That's when it's relaxing and filling up. You need to know this. These are always test questions, if not class, in the state. You have to represent and know how and what ways do we take blood pressures? By auscultation and palpation. You should have been taught that in skills. Auscultation, that means you're listening with your stethoscope and you're using a BP cuff. That's by auscultation. You get a top number and a bottom number. If it's by palpation, like 110 over P, you see that, you write that down. It's because that doctor or that nurse or the fellow EMT or medic's going to know when you took a blood pressure, you did it by palpation. You did not use a stethoscope, or you utilized with the BP cuff and checking the pulse and the radial pulse. That's how you did it. So know both ways, just in case they ask you that. And then, of course, your reassessment. So in your book, you get into your introduction. These are your 5 main parts: scene size of primary, history taken, secondary, and reassessment. We're going to go over each one, making sure when I see certain things in each section, I'm going to tell you, okay, make sure you understand this because you need to know this. You're going to see words like this coming up. Always test questions right here. You better know the difference between a sign and a symptom. So if I say, I feel nauseous, sign or symptom?
Symptom.
Symptom. I have a headache.
Symptom.
You see the difference?
Symptom is what the patient tells you, and
That's
sign
right.
is what you observe, right?
That's right. So you got to go according to what you see in your textbook also. How they break it down, I need you to know that also. You highlight that. In your textbook, it talks about the symptom being a subjective condition the patient feels and tells you about. That's what it says. A sign is an objective condition that you observe or you measure. Okay, you could do that. You need to know that. Okay, so remember, signs and symptoms. Highlight that in your book. Know that in your textbook, please. You continue with your scene size up. Everything we want you to do in your scene size up. Okay. Whatever the condition may be, whatever's going wrong, think of your safety first. Test question they always give you here. What's the main goal when you go onto the scene? Is your safety. Your safety first, your partner's safety, patient safety, then the bystanders, in that order. Always your safety first and your partner. Remember that, because they may ask you that on a test question. Now you get in here, no matter what is the scene safety, whatever. I don't care if it's the terrain, the weather, people going all crazy and want to beat the crap out of you. Safety first, right? I'm not staying in on that scene. I'm calling for PD. I'm calling for the police officers to come because all I have is a stethoscope and maybe a nice pair of shears and a BP cuff. What much I could do with that? And maybe with my agency, you would be like me and you wear bulletproof vests. I always did. Since 1988, I've been wearing bulletproof vests. Okay. But that's not going to protect me. You need to be protected, right? So scene safety always first, your safety first. So whatever the problem, road conditions, whatever, make sure you know your safety's first. The terrain to do with the weather. Okay. Whatever it may be, a hurricane, a flood, a storm going on. Continue here. And you notice is the same thing. Continue, continue. So you look out for any hazards, the environment. You go to a house and let's say it's or apartment building or abandoned building. It's like a crack den or something. There's a lot of people take drugs there and hang out there, things like that. You got to look out for all these containers around there, these needles and whatever it may be. Okay. This word you always need to know. MOI, mechanism of injury represents trauma. If I slap you or I punch you or I hit you with a stick or a bat or hit you with a car, that's trauma. Okay? Make sure you know trauma is trauma. Okay? That's a form of what we call also blunt trauma. Okay? Blunt trauma. MOI, mechanism of injury. There goes. Blunt trauma. If I stab you with an ice pick, a shank, whatever I have, a bullet, I shoot you, a bow and arrow, penetrating trauma. Okay? Make sure you know the difference between the word blunt trauma and penetrating trauma. It's in your book. Make sure you highlight that. There goes the penetrating. So you know the difference between blunt and penetrating. They ask you test questions. You know how to separate those two. Here, you need to separate NOI from MOI. Remember, this always represents medical, nature of illness. Okay, make sure you understand the nature of illness. I don't know what page is on your book, highlighted, but I know it's after I figure 10-3, determine the mechanism of injury and the nature of illness in your book. I'm not sure of the page, but go to that and you want to highlight the mechanism of injury and the nature of illness, okay? Remember, always read the small print underneath that, and that's on the following page, the nature of illness. Then you're going to see the word chief complaint. You must know the chief complaint. Separated from the subjective assessment. Okay, what I mean by that is, if I'm telling you I'm having chest pains, that is my chief complaint. If I say it feels like an elephant sitting on my chest, I'm describing more of that chief complaint, and that's called your subjective assessment. This is how you need to write things and know things, because if they ask you test questions, you need to know the difference. Okay, now here, this word, MOI and NOI, these 3 letters each, there's a word called index of suspicion. You will see it again. I need you to know that word because the index of suspicion represents in medical trauma, but especially trauma, what is the underlying condition or the injury. In other words, let's say I take my fist, and Lewis, I'm going to use you as an example. I'm going to take my fist and I'm going to punch him right in his face with my right hand. Right in his face. Mechanism of injury is my fist. His face on the left side, because it's always the opposite of me. What is the index of suspicion? That means when Nuki punched him in his left side of his face, what condition, what underlying injuries could occur? Give me injuries when I punch Lewis in the left side of his face with my right hand.
Broken jaw.
Broken jaw, right? Broken jaw. What else?
Concussion.
Yeah, contusion, unconsciousness. I could probably knock him out, whatever it may be. But
Damn, Lewis, you're getting roasted, bro.
yeah, we're beating his butt up. You notice that? That's it. He's lucky we didn't use a stick or a bat and really knock his butt out, right? He'll be on the floor. He won't even have his glasses on like me, right? But you understand. So that is the index of suspicion. Know that word. You will see that in the future. Okay. There goes your carbon monoxide. We spoke about this already. Okay. Any questions on this carbon monoxide poisoning? Okay. You know the things I told you to highlight, know what it is, right? Okay. Okay, PPE. What did I say about the PPE? We know that PPE.
Always wearing it.
Say that again, Louis?
We're always wearing it no matter what.
Yeah, always wearing things, right? There's things that we tell you to wear, but your personal equipment, you notice what he's wearing? He has his mask, he has his goggles, and he has his gloves, right? And we know that this falls under your standard precautions under the PPE, but the standard precautions to do with who? To do with the CDC, okay? Because they're worrying about you to do with fluids and blood and so forth, okay? So where in your book, when it talks about PPE, that's your personal protective equipment, you consider everything else that they're talking about. When they talk about that personal protective equipment, they're talking about the helmet, they're talking about the turnout jacket, the coat, the jacket, the bunker pants, the boots, the leather gloves. That's all a form of PPE also. But when it gets into the CDC portion of standard precautions, okay, that is to do with the CDC. You got to make sure that you're protected against all this blood and fluid and so forth. So know the words, standard precautions. They love to give you that on exams. Okay, make sure you highlight that in your book. So these are all your standard precautions, objects, blood, body fluids, things like that. You know, if I don't know you, I'm wearing gloves. You're a new patient and I'm coming to you and I never seen you, I'm wearing gloves. Okay. And I'm going to put those good nitrile gloves on and make sure they're all the way down here and wearing them properly. Right. Why? I need to wear that to protect myself. You should not be going home with your uniform on. You go and you come from your house to the job, but when you go home, you should be wearing your civvies. Okay. Don't go and wear what you wore to work all day and your boots and everything that has all this gook and nastiness on it, and then bringing it to your family, and then walking with your boots that you probably stepped on poop, urine, blood, whatever, and then you're bringing it home. Okay, hold on. Someone's asking a question. Yes, it makes sense, John. People forget that. Nuki had 5 sets of uniforms always in his locker. I'm former military from the Marine Corps, okay? And I always was straight out. My wife, still my wife, my clothing, military, and even for EMS, that the crease, you could get cut by the crease of it. That's how sharp starch it was. I always had it. People would look at my boots and say, damn, Nuki, you look good. I said, you're damn right I do. Okay, I'm always squared away. I'm a former Marine. I don't got time to walk in there with my hat backwards and smell like butt and things like that. No way. It's good hygiene. You know, when I go to your apartment, your home, you're going to say, oh, not only he's a handsome Puerto Rican Filipino, but this man, he knows what he's doing. You know, that's a difference than me going in there. You code EMS? What's the problem? You know, you're there like you don't give a crap. You know, you don't do this. You were taught in the first few chapters attributes. You have a lot of these attributes already, things you do that you learn from your parents, your brother, sister, uncle, aunt, whoever, right? So whatever job you're in now, you learned this already. So now you bring this to EMS, but it's slightly different. So make sure you know about everything we talked about before. Okay, let's continue here. There goes your gloves, your mask we already spoke about. If I don't continue staying on this because we got so much to go through. Determine the number of patients. You'll see a word called MCI, mass casualty right here. This word right here, multiple persons, an incident. So I want you to know MCI stands for mass or multiple casualty incident. Okay, there's always a person in charge, which is the incident commander. And then there's everyone else after that. And then you see a word called triage. That means to sort. Make sure you know that word, triage, to sort. It's directly from your book, okay? Make sure you know that. You'll see a word called Instant Command and System. They're telling you to do all that FEMA, right? You're supposed to do a certain amount of the FEMA certifications. I think it's ICS 100, 200, 700, 800, hazmat. And then they're telling you also to do, what's the other one? Mandate reporter, something to do with New York State. These are all certifications that are required by New York State. Okay, so make sure you do that. Do not waste time on this. Get it done as soon as possible. The quicker you do it, it's good. When in doubt, you need help, ask Dr. Google or Professor Google. That's what I do. I'm sorry. Everybody knows the ways and things. I think I know we're being recorded, but I'm just letting you know sometimes you need help. So, yeah, there you go. And that's right. You do ask the Professor Google. I do. You know, when I'm not sure of something, I go right there. Okay, let's continue. So we know that this is a level A suit, hazmat suit, one of the best. Okay. They ask you a test question that this suit, why is one of the best? Level A is because it's encapsulated. In other words, everything is underneath it. Okay. So the oxygen, everything, and it's taped real good. So nothing's getting in there. Okay. All the other ones right now, what we're wearing is called level D. That's what we have on. And then C is the other one where you see them all in white, and then they have a mask on and the oxygen is outside. And then you have other ones like that, like a B. And then what we're wearing is the D. So A is the best one. Okay. So make sure you know that's a level A. When you consider backup, you call ALS or law enforcement or PD. When in doubt, call for medics. When you're new and you're not sure, you know, try your best to talk to your partner first and learn. And then when in doubt, if you know the patient really needs ALS, paramedics, you call them.
What do they mean by, can you go back to that side? What is air medical support? What is
medical support? You're going to learn this towards the end. This is going to learn when you may have to act a dispatcher, depending what state you're in, that you need what we call flight medics. So in New York City, they only have like PD to do with, I forgot what is it, Floyd Benefield. I think there's helicopters over there between the, what's that place? Someone help me out here with JFK is. Before JFK.
Is it Floyd Bennett Field?
Yes, Floyd Benefield. Thank you, John. Awesome. He remembers. There they used to have the PD who used to have their helicopters, and we would call for that. I don't know what they do in New York City still, if they're still utilizing them. I know in upstate, they have flight medics, okay? They have flight nurses. So that's your air medical support. You need someone right then and there to land. So they're going to teach you here in the book, the LZ, the landing zone, 100 by 100. You're going to learn all this in the future, but that's your air medical support, okay? Okay, primary assessment, we spoke about this, life threats, level of consciousness, okay? Remember what I said here? That is your APU, AVPOU, ABPOU. Do you remember what AVPOU stands for? Anyone needs help with that, or they're comfortable with that?
I think I might have forgotten because I wrote down so many of them.
It's okay. That's why we
isn't that alert, verbal pain, and unconsciousness?
Unresponsiveness.
Oh, unresponsiveness.
Yes. The reason
not unconscious.
No. The reason why I separate those two in this way, what is the difference between the person being unresponsive and the patient being unconscious? An unconscious patient, their neurological parts of their neurons and so forth will still show some kind of stimuli, in the sense that twitch or whatever, the body will still respond, even to like a painful. When they're unresponsive, they're like comatose.
Got it.
Take a point and prick them in their face or somewhere around here, they're not even going to feel it. So see the difference?
Yeah.
I
see.
Okay, ABCs, you know. Don't forget that your life threats here supersede airway, breathing, circulation. And this is me, age, and the sex. 25-year-old male lying supine on the floor, on the street, on the sidewalk. I don't give race, but they tell you to, you can know this. There goes your general impression. You continue. You can add all this into it. You can highlight in your book. Don't go too crazy on this. Just read up on it again on your primary assessment and everything they want you to do in that section. They tell you when you look at the patient, look at them to see if they're unstable, potentially unstable, and stable. Okay. You normally do this in your decision making. If you notice under your primary, that's towards your end. But when you're giving that general impression, can you look at them real quick to see? Yeah, more or less you're doing that also. And that's what that general impression forms also. So if you feel it's something that you need to take care of, let's say they're bleeding profusely. Okay, you got to take care of that bleeding before you continue with the airway breathing circulation and so forth. If they ask you how you take care of bleeding, remember these 3 letters, DPT, direct pressure bandage tourniquet, DPT. That's how you take care of external bleeding. So if you see external bleeding and it has to be taken care of, you take some gauze, direct pressure, put it on them.
Can you repeat that? What it stands for?
Say that again. DPT, direct pressure bandage tourniquet. DPT, to control external bleeding, hemorrhaging. They use the word probably bleeding or external hemorrhaging.
Thank you.
You're welcome. That I'm not sure of the page, but I know it's after figure 10-8 on my side. And that's to do with the bleeding. And there goes the level of consciousness. And what I want you to know with this is, and it's coming up soon. Right there. That's important. Always test questions. You know what's the test question on the state here? You're going to laugh. One of the state test questions is this, in APU. A stands for, and they put the word alert. That's a test question in the state, just like that. That easy. The state is not that difficult. It's getting to the state. It's passing all LaGuardia's exams and going crazy in your time and effort. You need to know each one of this. So are they alert and oriented ×3 or ×4? What I mean by that, were they able to answer all your questions you asked them first time, one after the other, with no problem? Awesome. They're alert and oriented ×3 or ×4. They mess up on one of that, they're verbal. Okay? Verbal could also be, hello, sir, can you hear me? And they look at you, huh? And they don't say much after that. They're verbal. They're lying supine on the floor. You try the A, you try the V, nothing. So you pinch them and you do one of these. You pinch them like one of these things like it's in your book. And then when they don't respond to any of that, you're saying, well, if they do respond to that, they're paying for stimuli. If they don't respond to that, they're unresponsive. And that's what you need to know with this AVPU that falls under your mental status in your patient assessment. Okay? And then the questions you ask them to level of consciousness. Person, place, time, and event. Okay, you need to know that. So person, remember his or her name. The place identifies their current location. The time, the current year, month, date, whatever you want to ask them. And the event describes what happened. You need to know this. That's how you get the alert and oriented ×4. Okay, these are all things that you can see as a life threat. Airway obstruction is a life threat. Respiratory failure is a life threat. Remember, it starts with respiratory distress, then goes to a form of respiratory failure, then probably into respiratory arrest, and then into cardiac arrest. If they have a form of shock, that's a life threat. Okay? Severe bleeding. Bleeding a lot, that's a life threat. That supersedes the ABCD. Remember the spurting of the carotid artery, the radial artery, spurting of that. That's a life threat. Okay, things like that. And of course, cardiac arrest, no pulse, no breathing. So you need to know this just in case. Now, what separates ABC from CAB? Anybody? What's the difference between
Level
the
of consciousness. Well, no.
Go ahead. Besides level of consciousness, what else?
Cardiac
Cardiac arrest.
That's right. One of them, you're in cardiac arrest. You're doing a CAB. You learned that in CPR, right? They're in cardiac arrest. You got to make sure you take care of that.
So only in CAB they will be in cardiac arrest.
Well, CAB, you're performing chest compressions, airway
Huh?
breathing. So it's compressions, airway breathing. So you know this is when they have no pulse and no breathing. Okay.
Okay.
But you could determine all that in the beginning, right? You could determine that in your scene size up, and then when you're doing your
Yeah.
primary, and you'll know right then and there. Because a lot of you, you're going to learn when you go out in the field or on the street and you're learning. One of the first things you see when you got an unconscious patient there, besides a person holding head stabilization, they're checking that pulse real quick while the other person is doing the rest of the assessment. They're going to say, partner, I don't feel a pulse. Are they breathing? No, they're not breathing. Oh, they're in cardiac arrest. See, that's how quick it's going to be in the street, in the field. But right now, we're trying to teach you all in order. So know the CAB. Besides this, look at that patent airway. That means normal. Everything's good. You need to know that. Give me 1 minute. Was everybody able to sign in? If you didn't sign out and sign back in, I have how many people here? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. But I only have 8 people who signed in. Okay. So you got to make sure on this. Try to do that if you get a chance. If not, if you didn't get to sign in yet, because there's a problem, please email me. Okay, I'm going to give you the email again, because once I close this, I cannot open it again. This is my email. So I can make sure you get the credit, because I have to email all your names to Christine and to your senior instructors. There it goes. medicnuki@gmail.com, okay? I'm in the poll now. Okay, that takes care of that. So note painting airway, that's normal. You look at the responsive patient, okay, what you need to do for the patient. Remember, in a conscious patient, do I need to check a carotid pulse? No. Yeah, radio, excellent. Isaiah, that's right. You check the radio pulses, make sure they're there, especially in the beginning of your ABC. You know, that's your so-called VCRs on the circulations. You know, if they were unconscious, I see you going for the carotid and then the radio. Okay, because if you go first for the radio, while you're doing the skill, the instructor is going to say there's no distal pulses. That means no peripheral pulses. They want you to go to the carotid. So be prepared when they give you and they test you like that, skill-wise also. There goes your unresponsive patient. You know how to open up the airway. If it's medical, head, toe, chin lift. If it's trauma, jaw thrust. Okay? Yes, question?
Yeah, can you hear me?
Yes.
I remember during the skill, it was like bilateral radio. Is a difference when you have to do that or not?
No, that's excellent. I'm glad you bring that up. Yes, when you were doing the skill and you were checking both pulses on the floor when the patient was lying supine, you do both radio pulses on the same time. They want you to do that. Okay. And most likely they'll tell you if it's an unconscious patient, go to carotid first, then check both radio pulses at the same time. They want to make sure you give a good comparison, because that tells you a lot. If they have good radio pulses, that tells you more or less that the systolic blood pressure will be at least 80 or better. Remember these numbers. Good radio pulse, 80. Good carotid, 60 plus. Good femoral, 70 plus. So 80, 70 femoral, 60 carotid. They're telling you if you got good, strong pulses there and regular, that the systolic could be about that number. So 80 on the radial, 70 on the femoral, 60 on the carotid, okay? Make sure you double check with your instructors. Make sure they're still teaching that way. I'm going old school. They could have probably eliminated that. I'm not sure. But just double check it. You must check. And a guy tries, you put them both, set that. bilateral radial pulses. So here goes the head tilt chin lift, right? The jaw thrust. If it's trauma, you know this. You look for any signs of obstructions here. And then these words you need to know. Is there anyone here confused with the word snoring? Okay. Bubbling or gurgling, crowing or stridor, or any abnormal sounds. They're going to use the word adventitious sounds. That's how they get you. What are adventitious sounds? Abnormal. You need to know all upper airway and lower airway. I would attempt it, Maria. If they're unconscious, okay, I would give my patient oxygen, okay? If you try to put in the OPA and they gag, you take it out and you're just going to BVM that. You have to look at that patient, what do they need? So I definitely, depending, it could be some medical condition here, or it could be a trauma condition that you're not noticing yet. I definitely would give oxygen, even if you still have that good perfusion, okay? What's causing this breathing problem here, okay? Look at how many times a minute they're breathing. You know, is it regular or irregular? So it all depends. Majority of times when it comes to the state, they always say if you're BVM in a patient, that background mask, there should have been an OPA before that. Okay, that oropharyngeal airway. That's always a state test question. So be aware for that one. So any questions on this? Do you all know the sounds? And to get to it, and you have to. These are going to be test questions. I guarantee you.
Luke, I had a question.
Yes.
Is the I know Strider and that other crowing, is that the same thing? Or how is that different?
Well, crowing falls under Strider. Okay. So you should keep that together because crowing does fall under Strider. They use it as they say Strider is a high-pitched musical sound, crowing or ka sound. That is for Strider, upper airway. So I want you to think of some form of blockage, or it could be angioedema to do with swelling of the face, neck, and so forth. You need to know that Strider. And you need to know upon inspiration, them breathing in. Okay? Now, that gurgling or bubbling, I want you to think of fluid or blood in the upper airway. Like if you were taking Listerine or Scope and you're going, oh, whatever, just like that, okay? The snoring, you need to know that's blockage to do with the tongue. You'll have a snoring sound. The tongue is so relaxed that it goes towards the back to the side and it blocks the upper airway, so snoring. The word abnormal sounds is called adventitious sounds, and now you need to know the lower airway. And these are the ones they always ask you. What is wheezing? Wheezing upon exhalation, when they breathe out, that you'll hear wheezing. It could be anywhere from doing from asthmatic, COPD, chronic obstructive pulmonary disease, pneumonia, whatever it may be. The wheezing is constricting inflammation and possible mucus of the bronchioles. Okay, that's what you need to know with wheezing sound. If they say rails or crackles, that is fluid in the lungs. That's the sound you will hear. Here, they will use crackles or rails. If you hear like a congestion or a noise, like a rattling sound, they say that is rhonchi, lower airway. Know that when we get to it, it's in your book. I'm going to tell you to highlight that. So please make sure you know that.
Nuki, all of those names you just said, those are all now in the lower airway of the body, correct?
Lower airway of the lungs. I'm going to give it to you again.
Oh, lower airway of the lungs. Okay.
Lower airway of the lungs, the sound. So wheezing, rails, crackles, rhonchi. Wheezing, think of constriction, inflammation, and mucus of the bronchioles. Okay, that's wheezing. So think of asthmatics, COPDers, pneumonia. That's where you probably have that wheezing when they breathe out upon exhalation. Then I gave you the rails and crackles. Okay, that's to do with fluid in the lungs, a form of what we call pulmonary edema. Pulmonary edema. Make sure you know that. Then you may have rhonchi. Rhonchi, you get that a lot in pneumonia, okay? And you could have a nosy sound like a rattling. That's what they call it. And it's called rhonchi. That's all lower. Make sure you separate upper airway from lower airway because they ask you the difference for sure. Okay, the breathing, you need to know that. We went over a lot of the sounds. This number you have to know, 8 and 28. Less than 8, okay? Could rails appear as a pink fluid, correct? If you have a productive cough, John, okay, like a congested heart failure or acute pulmonary edema, it is possible that productive cough, they come up with that pink frothy sputum, it's called. Okay, that is a possibility because it's coming up with specks of blood in it. Okay, so not all the time. So it all depends. Sometimes they won't even have that cough yet, but you need to know the sound that they have fluid in the lungs developing. But that's a good thing that you brought that up. That's good. Now, 8 or 28. So less than 8, more than 28, EMTs ventilate, medics intubate. I'll say it again. 8 or less or 28 or more, EMTs ventilate, okay? Medics intubate. Understand that. So don't only look at that number, look at the other signs and symptoms you see there. Always test questions, okay? And there goes your pulse ox, 94 to 99. That's the number you want to know. You got to separate the words like, spontaneous respirations and inadequate respirations. You're going to get words like, I'm going to bring it up for you right now. These words here, you need to know each and every one of these. Sniffing position, tripod position, labored breathing, two-word dyspnea, nasal flaring, accessory muscle use, retractions. Each one of these. Is there any one of you here not sure with these? These are future test questions. Could be on the exam coming up, or it could be on future test questions to do with cardiac related, respiratory related, pediatrics, whatever. You need to know the difference. So I need to know, is there any question if I say retractions or if I say a thing? Yes. Retractions, I want you to think of intercostal muscles and retractions here. When they breathe in, especially the children, their chest caves in, okay? Some form of sternal retractions. If it's accessory muscle use, I want you to think of the neck muscles here, and you'll see it like go up, like here, like if it's pulling. So that's accessory muscle use. Nasal flaring, look at Nuki's nose. See it? That's nasal flaring. 2 to 3 word dyspnea, patient will go, I can't breathe. 2 to 3 word dyspnea. Tripod, the hands could be on their knees like this, leaning forward. Okay, so you need to know that tripod position. Okay, that sniffing position is like this, like they're almost sniffing, like sniffing position. So you need to know this, especially seen in children. Labored breathing, you have to know that breathing there is a little more difficult than shallow respirations or shallow breathing. That labored breathing, there's a harder effort in the sense of their positioning, how they're breathing, their depth of the breathing, their tidal volume, okay? They not using the accessory muscles and all the muscles like they should, so you'll see it different on their body. That is a form of what we call labored breathing. So in your textbook, make sure you highlight all these words and read further down, make flashcards of it, whatever, to know these meaning. Because when you see it on scenario critical thinking test questions, it's easier for you to answer it. A lot of you are going to be able to answer straight general knowledge questions. You know it or you don't. Okay? Is the scenario based and the critical thinking questions that gets most of everybody, all the students. When they give you a nice scenario and you're like, what are they trying to ask here? If you break it down in signs and symptoms, it's easier. That's why I try to go through everything, make sure you understand it, So when you see test questions like this, it's easier. Okay, respiratory distress, know this word, increased work of breathing, increased effort and rate. It always starts with some form of respiratory distress. Then they go into probably what we call this one, respiratory failure. That occurs when the blood is inadequate, oxygenated, or ventilation is inadequate to meet the oxygen demands of the body. The ultimate result of respiratory failure, if it's not corrected, okay? And then they probably could go into respiratory arrest. It means they won't be breathing at all, or the breathing is inadequate or absent, and they only have a pulse, and it could be there being weak. They're in respiratory arrest, not cardiac arrest. Cardiac arrest is when the last thing they go into, no pulse, no breathing. Okay, so make sure you know these words when you see it in your book.
So respiratory failure, like you just said, is different from a cardiac arrest. But if someone's in respiratory failure, would you still perform like the BVM and all that type of stuff?
Yeah, there you go. I'm glad and like what you're thinking, Kelly. Did you have to perform maybe the BVM if the patient is some kind of respiratory failure? Yes. It depends what you get. Are they pale, cool, diaphoretic, or is there cyanosis there? How's their breathing? Is it less than 12 or more than 20? And is it higher, less than 8, more than 28? Do you need to assist their ventilations? Yes. Because if you don't, they may go into respiratory arrest, that now you have no choice but to use the BVM because their breathing is inadequate or absent. That is a form of skill that you're going to be doing with the BVM. And if nothing's done or you get there too late and they go into now cardiac arrest. But yes, you can ventilate that patient in a form of what we call respiratory failure. You got to look for the other signs and symptoms of what you see there. So remember, respiratory distress first, this one first, then this one. Okay?
Okay.
Then possible can lead to respiratory arrest and then cardiac arrest. Okay, make sure you know the difference and the signs and symptoms between distress and failure. If you notice, and there's a nice table in your book, 10-2. It says signs of respiratory distress and failure. Read that and look at the difference, okay? What you may see in respiratory distress and respiratory failure. And that would tell you more or less, wow, I may get to a point here that I definitely going to have to what? Ventilate this patient. See the respiratory distress when you get to your book, table 10-2. I don't know what page is on your book, but look for that table 10-2. And then mental status, pulse, and skin conditions and circulation. You're going to get to that. The test questions we always give here is the VCRs. So you need to know what the pulse means, okay? To determine a pulse, you need to palpate that pulse, right? What's the first pulse you always go to that you notice that they teach you in class? What is the first pulse they always teach you?
The radio?
The radio. Isaiah said it earlier. They always teach you how to check a pulse and how they do it here and counting. And then when they give you the patient assessment, they said, I want you to take bilateral pulses, distal at the same time, right? But when you're doing pulses, they teach you a certain technique and they teach you to do it for 30 seconds times 2, just like your respirations, 30 seconds times 2. And if they're both irregular, they want you to do it for the whole minute. That's how you taught in your patient assessment in class when you were doing vital signs and everything. Posting here, you need to know the word, what it means, and what is occurring right here, right? That pulse wave that occurs in each heartbeat causes a surge in the blood circulating through the arteries. That could be a test question. Make sure you know that. Now, you need to know the difference in pulses. If I say a brachial pulse, most likely I'm checking a brachial pulse on what type of patient?
Baby.
Babies, infants, 1 or less, right? Brachial. So my test questions for you would be this. Give me the central pulses of the adult. And you better know it's the carotid and femoral central pulses of the adult. If I say, give me the central pulses of your infant, you better know it's the brachial and the femoral. If I say, what are the peripheral or distal pulses on each of these patients? You better know what I mean. distal pulses or peripheral means distally. So you would think it on the upper extremity, the radial pulse, that's distally. If you're thinking the feet or the legs, you're looking for distal or peripheral pulses. You're thinking of the salus pedis and the posterior tibial. You need to know all the pulses that are very important. So know the words I just gave you: distal and peripheral and central pulses. So remember, 1 year old or down, you could go for that brachial. Past 1 year old, up, you go for that carotid. You know the skin condition, you know this CTC. I'm not going to go over crazy with this. You know all the different conditions: dry, moist, wet, diaphoretic, whatever words you want to utilize. You know the colors, right? If I say yellow, what color would you give me?
Jaundice,
Jaundice. If I say blue,
cyanosis,
if I say red,
Cirrhosis?
you red, you normally go with a flush color. Okay, that's how they give you that test wise. Okay, if I say white,
Pale?
pale. Some people use pale, pallor, and so forth, right? John, retractions again? You need to go over that again? Or we're good with that?
oh no, I'm good.
Okay, I just saw it just now. I'm sorry about that. My apologies.
Okay.
Okay, there goes cyanotic, cyanosis there. Okay. Skin temperature, there's 4 we always talk about, right? Skin temperature, warm, cold, hot or cool, right? So hot or cold, warm or cool. That's what we talk about. Conditions, dry, moist, diaphoretic, things like that. Cap refill, under how many seconds means it's good? CRT, capillary refill time, under how many seconds?
2.
2. Anything more, the word they use is considered delayed. So when you check this, cap refill, they're going to ask you CRT time. When is it good? 2 seconds or less. When is considered, not good? Delayed, more than 2 seconds. So you need to know cap refill. So know that number. Restores to normal within 2 seconds. Okay? Here, they ask you about any kind of bleeding. You're going to learn bleeding in the future. This is what we were talking about more before. An artery, it's spurt. It's under a lot of pressure, spurting. That's the artery. A vein is a steady flow. Okay? A capillary oozes out. Oozes. So know these different terms. Okay? That's to do with bleeding and to do with the different blood vessels. Remember this one? DPT. Direct pressure, pressure bandage, tourniquet. You need to know that. Make sure you understand that. Now,
I have a question.
yes, Isaiah. Am I saying your name correctly?
Yeah, you saying my name correctly.
Yeah.
You said for an unconscious patient, you're supposed to check the carotid and the femoral artery.
No, I didn't say that. I said that you need to know all the pulses. But if you have a patient assessment and you're doing the unconscious patient, one of the first pulses they want you to check is the carotid to make sure you have a good carotid. If for some reason, when you don't, they're going to say then you could technically check the femoral.
Okay.
So I gave you numbers there, but when it comes to tests, I wanted you to know all the different numbers. So if I say the carotid, if you check my carotid, Isaiah, I should have at least 60 beats or better here, right? That's a good carotid. If you can't find a carotid, you're going to say, well, something's wrong here. Well, let me just double check the femoral. Maybe I'm not feeling it correctly. They got a good femoral, at least 70. Are you following me? 70.
Okay.
That's what I'm saying. But when you get tested skills-wise, when you get an unconscious or unresponsive patient, they most likely want you to go first to the carotid when you're doing your ABC. Okay? When you're in C, they want you to check the bleeding, the voids, and then the carotid, and then the radial. That is why it's called VCRs under circulation. Do you understand that?
Yes.
Okay, good. I want to make sure we're on the same page. Now, you perform a rapid assessment, 60 to 90 seconds, just like you would do that in a patient assessment. Your patient assessment, your scene size up, and your primary should be done no more than 90 seconds, 120 tops. What do I mean by that? When you go BSI, scene save, number of patient, additional resources, MOI, NOI, C-spine, that's scene size up. Then you get into your primary and you're doing general impression, mental status, chief complaint, life threats, and A, B, C, D. All that's done within 90 seconds tops. This is a physical rapid assessment. They're saying it should not be done more than 90 seconds. And that is skill drill 10-1 in your textbook. Okay, make sure you look at that when you get a chance.
Nuki,
Yes.
do you ask for the patient's history in this secondary assessment or first?
No, good question. Your secondary assessment is when you're doing the questions on your medical and your trauma when you do the sample. Okay, you're going to see on your skill sheets that all that should be done in your secondary. So if you're going medical wise, you do your scene size up, you do your primary, that's done. Now you're in your secondary. If you're doing medical, you could start with your sample if you want to in the OPQRSTI, or you could do vital signs first. So the textbook shows you a certain way. The skill sheet shows you vital signs, OPQRSTI, sample, and then your body system. That is in medical. If it's in trauma, watch this. You did your scene size up, you did your primary. Now you're in your secondary in trauma. This is how you're going to be tested. You're going to see right there, it's going to say HPI. That's history of present illness. They want you to get a sample. And then in order from head to toe is your DCAP BTLS. Okay, that's the difference. And I'm going to show you that here also when we get to it.
Okay,
Good question. Remember in your secondary.
all right.
Okay, these are all types of high priority patients. Okay, and transport, this is the different things that you may see. You can highlight that in your book. They may give you this as a test question called the golden period. Know the golden period, what that means, or they call it the golden hour. It's the time from the injury or to definitive care, during which a treatment of a patient in shock or traumatic injuries occur to maximize the patient's chance of survival. You're going to see like a circle, a clock, okay? You need to know that clock. I'm going to show it to you now. 10 minutes, the Platin 10 minutes could be a test question. 20 minutes here, discovery, incident, and activation of EMS. 30 minutes, EMS, initial hospital stabilization. That's the golden hour. Very important. The golden hour, also called the golden period, is the time during which treatment of shock or traumatic injuries is most critical and potential for survival is best. So if you see a test question, what is the Platin 10 minutes? Okay, you know it. Okay, what is the golden hour or the golden period? You know, in case they ask you. You may not see that. It all depends on your instructor. Depending on priority patient, that is your unstable, potentially unstable, stable. History taken, that's all to do with your sample, okay? And your OPQRSTI. So whatever they complain about, you're going to follow more on that with that history taken, and you're going to ask a bunch of questions.
Chief complaint, as in like the patient, right?
Chief complaint is what the patient tells you what's wrong with them. So if I ask you, Kelly, I'm paramedic Nuki, I'm here to help you. What seems to be the problem? You mentioned something, whatever you want to mention, Kelly. I have pains. Well, where do you have your pains at? In my abdomen. Where in your abdomen? My lower part, right here where my crotch area is. I have a very bad pain. Then I get into questions on that about your history. Are you having your menstrual? Is a possibility you could be pregnant? I'm thinking of everything. Is there any bleeding? You know, because a lot of issues for female could be lower right quad, appendicitis, ectopic pregnancy, you name it, a cyst, STDs. You follow me? So chief complaint, whatever I tell you what's wrong with me. And then you add more. If I add more, that's called the subjective assessment. You need to know those two different words. History taken, do your sample. Do your OPQ or STI. This is beautiful mnemonics. Is there any questions on your OPQ or STI or the sample? You need to know this. This is how they're gonna make sure you're doing your patient assessment correct. Okay, I need to know for sure. This is the time. This is all medical. This is not trauma. Trauma is what? DKBTLS, DKBTLS, DKBTLS. That's the head to toe. This is all medical. And if you're not sure, I'm going to show you one more time so you could see it. When you see it, how Nuki is separating medical and trauma, you're like, oh, okay, now I know what Nuki means.
Does I stand for identify pertinent negatives?
No, I is interventions, Jason. In
Oh,
other
okay.
words, what did they do prior to you getting there? You know how patients have a tendency of taking aspirin or something, or they take their inhaler before you get there, depending what's wrong with them. So you want to know, you know, OPQRSTI, excuse me, sir, ma'am, did you do or take anything prior to me getting there, coming here? Oh, yeah, I took my inhaler. Okay, good. Did that help or didn't help? And so forth. Oh, cardiac related. What did you take? Did you take anything before I arrived? Yeah, I took some baby aspirin. Okay, how many milligrams? You follow me? Not what we're going to do. That would be our intervention. Now, Kelly, look at this.
Mhm.
You see the medical, right?
Yeah.
You see how I got the scene size up, the primary, and then you see the secondary, how they did vital signs first, the OPQRSTI, the sample, ample, and then the body system, and so
Yeah.
forth. Now, you notice it's a lot of questions, a little hands-on here, and then a lot of questions, right? Now,
Yeah.
watch trauma. Trauma, they read this to you. They give you a scenario. Now, look at trauma. Look at that. You got an extra critical here that you better say, right? You
Yep.
said 6 things. You did your primary. Now, watch the secondary. You notice that the secondary, they start with the sample, which is your history, and then they did a head to toe straight down, and then they put in the vital signs and manage any secondary injuries or wounds or appropriately, right? And verbalize your interventions. These are all points. So that means in order for me to pass this skill, that's 52 points without hitting a critical, I must get at least 37 points or better. So you see the difference between trauma and medical.
Okay.
Does that make you relax a little more?
It does.
Understand a little more? Because you need to know the difference.
Mhm.
Okay, when I send you all these other stuff, I want you to look at them as a guide, and you're going to understand it more. So when you go to the skills, don't be one of those students who do not participate and watch other people. No, get on the floor or say, I'll try. Even if you mess up, that's how you learn. Okay, if you're the ones that are behind going like this, you're not going to make it in this class. You're going to have problems. Participate, all of you, okay? Not bad. I'm glad you all understand this a little better. Give me 1 minute. There goes your sample. Any questions on the sample for any one of you? No? All right. All this I want.
Luke,
Yes.
I have a question. Okay,
Go
for
ahead.
sample on a unconscious patient, obviously they're unconscious. So how is it that you're performing the sample on someone who's unconscious?
Yes, you are going to ask a family member, friend, or bystander. That's how you do that when you're out in the field or when you're getting tested on a skill. So let's say they give you an unconscious patient hit by a car. You know they're unconscious. You did everything in the beginning. Now you finish your ABCD, and now you're getting to the trauma section when you have to do the sample and your DCAP BTLS. You ask an instructor, at this time, I'm going to try to get a history, a sample history. I know my patient is unresponsive, not able to answer any of my questions. Is there a family member, bystander around that I can ask? No or yes. Then I will ask them to sample. If there's not, boom, you got the points. Out in the street, it's the same thing. If you can't get it, you can't get it. What we're trying to see, do you know the steps, Louis? That's what it comes down to. But you're right. It's impossible to get a sample from the unconscious or unresponsive patient, but there got to be someone around it. If there's no one in real life scenarios, you do what you were taught. You follow a certain order and you take care of it and you'll be fine. Okay? Is it that important? To a certain point, yeah, if you could get that information, but if it's not, it is what it is. Okay? Excellent question. All these gathering, elevating, synthesizing, all this, make cards out of this. It's in your book. Okay? The ones I look at is when I get to each one, I'll find it here. Intoxication. I tell you, be very careful with this type of patient. What you look for in the intoxicated. Depression. Okay. Depression is well known. Okay. These are things that are what we call functional disorders. In other words, depression, anxiety, schizophrenia, bipolar. These are what we call functional disorders. They cannot be pinpointed. Okay, organic brain syndrome, which you're going to learn in your book. These are incidents or things that actually could be pinpointed. In other words, hypoxia, low sugar, head trauma. You can actually pinpoint what's going on with them. Okay, and treat it accordingly. In depression, anxiety, bipolar, and schizophrenia, you can't. You know. We always ask the question, what is the difference between a psychologist and a psychiatrist?
A psychologist is more mental.
One's a doctor.
There you go. We're getting close, Kelly, but Jason is right. One's a doctor and can prescribe medication, one doesn't. Okay? So the one who could prescribe this medication, right? He's telling you everything that he learned all these years, and he could give you medication for this condition. But still, when it gets to a point, it's not like we could pinpoint the gene that causes anxiety or depression, or a person who's bipolar, or a person who has, what's that other one? When they have multiple personality.
Personality disorder.
Yeah, we can't pinpoint that. It just happens.
MDID, there's a bunch now.
Yeah, right? You're right, Kenneth. So let's continue here. That I just want you to go over and read. Language barriers, always test questions. They're going to ask you, person who's blind, or person, vision impaired, or visual impaired, or deaf. If they're deaf, they want you to be able to give them a piece of paper, pencil, or stand in front of them. Okay. If they have a visual impairment, like blind, they're going to mention the dog with a certain harness over them. That's what we call the guide dog. So they may ask you a test question like that in the future. So you need to know this to do with language barriers, hearing problems, and also visual impairments. Okay. And then, of course, you get into what? Your secondary. And your secondary is everything you need to know. I'm going to give you a break now. I've been talking like for an hour and a half here. Okay. And I know I have to eat. And I saw Isaiah eating a little something, and he made me hungry. He didn't even offer. Nuki, did you eat yet? No, I'm diabetic and I should be eating. I'm only joking with you, Isaiah. But he's smart. He's like, I'm going to go grab me something while Nuki continue talking. How long you want to take your break for? Because we're almost done with this. We're going through a lot, but at least you're going to have the video on this. Okay? Talk to me. Sorry. When I remember it, I'll let you know. Yes, Kenneth.
Oh, that's me muting my mic doing this. That's me muting it.
Oh, I'm sorry. I thought you was asking a question. For a minute, I thought you were going to make some kind of form of gang signs or something like that. I'm only joking. No gangs to me. That was my youth. You say, Nuki, you was in a gang? Yeah, I was a tremendo títere. Anybody who knows what
Okay.
tica means in Spanish, you go, yep, Nuki was gangster. And don't believe how I got into EMS after all those years after, right? The little demon, that's what I was.
You see some things when you're in a gang.
Huh?
I said, well, you see some things, so maybe some of those things made you want to be an EMT.
I don't know. I just know that blood and guts, I love. God forgive me. Stabbings and shootings and people sick. I have a job. I just me. You know, I see decapitations 4 different times, head right off. I'm like, oh, that's so cool. That's just me. It's not like you see in the shows. I mean, I actually see it physically right there. So sorry about that. Let's get into this for you all so we could be done hopefully a good time and you could enjoy the rest of your day. And good luck on your exam. When you're taking the exam, Tuesday?
Yeah.
Yes, sir.
Yes. To my knowledge, it's going to be all patient assessment. We're going to go over certain things to make sure you do very well. You got to continue doing well. Okay, that's what counts. So
Nuki, I had a question before you
Yes.
continue.
go ahead, Kelly. I'm here for you.
Okay, so it popped into my mind when you were talking about patients with depression and stress or whatever. So I was thinking, what if you arrive at a scene and there's a patient that's very suicidal and you get there before PD does? Are we allowed to prevent them from, like, let's say, God forbid, jumping off a building or about to hang themselves? Like, what do we do in that situation?
If you were there before PD gets there and you was to see that, yes, you probably could talk to them. But if they're right there suicidal in their home and they have a knife and things like that, you want to step away from that. You want to back up. Your scene safety is first. What they call the old EDPs, which is now known as excited or agitated delirium. That's the name they use now for these patients. Your safety is first. You have to treat them when the time comes, but we don't want you to try to go over there and physically, take them down, anything like that. That's all to do with being a police officer. But can you talk to them? If a person's suicidal, they're homicidal. In other words, that's a test question always. If they want to hurt themselves, they're suicidal, they're homicidal. So your safety is first. So be careful. I have had many patients who were suicidal, homicidal, that I spoke to them and calmed them down. Even with PD being there, that they didn't have to physically stop them and not like you see it on TV, like Blue Bloods and all this other stuff that they tase them and all this other BS. Okay. They're being very careful with EDPs now because if you see what's happening out there a lot with the police officers, and I'm mentioning it here, and it may come out awkward, and no offense to anybody here, but it's mostly a patient of color, a minority. If you notice it a lot, when it comes to officers, depending on how they're trained, is also depending on the color of your skin. Okay, so I'm telling you, you have to be careful. So when you're there with the police officers, you let them do their job. But if you could do your job before they even get there, try it. But if they have like a knife or something like that, no, don't even approach them. Let cops do what they got to do first. Your safety is first. You want to go home back to your family. And I have dealt with that many times as an EMT and also as a medic out in the street. So be careful there when you get to that, okay? Now, we're going to get into this secondary assessment. Secondary, this is the test questions they always give you. When you're doing head to toe, you need to know these 3 words. Inspect, palpate, auscultate. Highlight that in your book. Inspect, palpate, auscultate. Always test questions they give you on that. You have to follow that sequence. Inspect, palpate, and auscultate. Very important. When you're going to do that mnemonic that you see the decap BTLS, besides doing this, is this. That's the one that I showed you before, Kelly. And I said, you see medical and then you see trauma and you see history that Isaiah said, okay, Mr. Nuki, do we do the sample there? And then right after that, is it also medical and trauma or only for the unconscious? I said, no. Even Lewis came out with a question on that. You have to do the decap BTLS. So that is your head to toe. That is your secondary. This is trauma. Please let me know, make sure, because you're going to get test questions on this. If I ask you what is C in decap BTLS, what C stands for? What will you tell me?
Contusions.
Contusions. If I ask you B, what's B stand for?
Bruises or
Burns.
No, yeah.
oh,
Burns.
right? So you have to know each letter and represent, because we're going to ask you the OPQRSTI. We're going to ask you sample. We may ask you what's the E in sample. We may ask you what's the P in OPQRSTI. You need to know it's provocation and palliation. What makes it better or worse? So you get test questions like that, class and in the state. So know this head to toe, DCAP, BTLS. Deformities, contusions, abrasions, penetrations and punctures, burns, tenderness, lacerations, and swelling. I'll say it again. Deformities, contusions, abrasions, penetrations or punctures, burns, tenderness, lacerations, and swelling. DCAP, BTLS, DCAP, BTLS, DCAP, BTLS. All this is in your secondary. They say you could do a lot of this and identify things within the first, technically, 60 to 90 seconds. And it's true. When you go in DCAP, BTLS, you're doing this. Okay, so make sure you know that in trauma, that is not medical. Someone here, who's this? Maria, thank you so much. Maria types so quick and so fast, but she's able to put a lot of good information here for all of you to do with sample, OPQRST, and don't forget, I include the I, that's interventions. Thank you, Maria.
I would love to take the credit, but it's actually Jason. Jason typing. I don't know why it shows up as my name, but he is
Everyone's
the one
Maria
typing
today.
right now.
Okay, Jason, then thank you. Whoever.
I'll take the credit though.
All of you. My question is, because I got to make sure I have all of you. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. I have 11 of you here. I got to make sure I send all 11 to Christine and your other instructors, your senior instructors. Please, if you did not get to sign in, email me so I can make sure you get the credit. It should still show you, but if it don't show you signed in, I have to double check on the reports, okay? So you form that good focus assessment, you know the MOI, you do that sequence of DCAP, BTLS. Each one of these now coming up represents your respiratory system. You need to do everything in respiratory, what we stated before. I need you to know the words like tidal volume, retractions, accessory muscle use, okay? You need to know the difference between labored breathing and shallow breathing. You need to know the rate. What is the respiratory rate? When you do the patient assessment, you take the good tidal volume and you see how much they're breathing in and out within 30 seconds, and then you times it by 2. You do that when you check a pulse. So you have to give a rate, rhythm, and quality. Make sure you know that. That's always test questions. So you give a rate, you need to know the rhythm. Is the rhythm regular or irregular? What is the quality of breathing? Okay? If it's full and adequate, is it shallow? Is it labored? Okay, you need to know words like that. So when they give you a test question, they say words like a reduction in tidal volume, reduced tidal volume. You know that's not good. It should be normal. That breath that they take in and out in 1 second, right? They have to have good tidal volume. So know the rate. You know this number already, okay? You know it's 30 seconds times 2. If it's irregular, you do it for the whole 60 seconds. That's always a test question. You need to know the rhythm, regular and irregular. We already went over that, okay? You need to know the quality of breathing. Normal breathing is silent, no noise. So if you hear a bunch of different sounds, you need to know, is that upper related or lower related? And we went through every one. The depth, amount of air in and out, okay? That good exchange, that good tidal volume. The breath sounds, make sure it's not adventitious sounds, okay? A good EMT would do what? They should have taught you to check your lung sounds bilaterally. Mid-clavicular, one set. Mid-axillary, base and base. How I do it, and it's going to be funny, and I'm not trying to be nasty to no one here, ladies or gentlemen. Nuki touches his nipples, okay? And then I go halfway up. Okay. Yeah, I know it's kind of funny, Kenny. Kenny's like dying. Nikki, are you serious? Yes, I'm serious as a cardiac.
Bro, you were going in circles. Come on.
Right? What I was doing, Kenny? What?
Said you're rubbing them in circles, bro. Come
No,
on.
I'm not doing that. I'm not going like tuning Tokyo or anything like that. Jesus Christ, you crazy. But watch. Mid-clavicular, mid-clavicular. Go back, mid-axillary, mid-axillary, base and base. Good EMT knows 3 sets, 6 spots, right? Can you do it like this also? Can you check it like this, or you could check the back? Yes, you can. So that's another 2 different sets. If I was doing 5 different sets, 10 points, I would have done the 3 front or the two front, mid-clavicular, mid-clavicular, mid-axillary, mid-axillary, then the base, then the base. Then I would go to the back here, and I would do it here, 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 and here. That's me doing 10 different points or spots, right? Which is 5 sets. But I do it bilaterally. I make sure. That's if you have the time. But the minimum they want you to do, check this out depending, they say it's 2. But a good EMT on medical would check 4 different spots or all 6 to make sure. You definitely want to do mid-clavicular and mid-axillary, and then the bases. You look for all this. Is anyone here confused at any of these sounds? Look at them. If I point to here, you know normal breathing is silent, no noise, everything's good, in and out, right? If I say snore breathing, what are you thinking about? Automatically, snoring.
Sleepy.
Besides sleepy, what
Tongue.
happens? Tongue blocking the airway. If I say wheezing,
Asthma.
asthma,
Bronchitis.
right? Lower airway, snoring, upper airway. If I say crackles,
Lower airway, lungs.
lower airway, lungs, crackles, rails, right? That's fluid in the lungs. If I say bronchi,
Lower airway.
it is lower airway. What else? What's the sound you hear?
Mm.
Remember, it was like that rattling, noisy sound I said? And then stridor, you know this one,
Strider is the upper.
upper airway.
It's
and
like
give me
a.
the 3 I mentioned.
High pitch.
High pitch musical, ha or crowing.
Ha.
There you go. That's the words they utilize a lot. In cardiovascular system, what you're looking for, chest, listen to breath sounds. Can you listen also to the respiratory rate, do the blood pressure, pay attention to the rate, rhythm, and quality? Same thing here. Can you learn and do heart sounds? Yeah. Okay. Next to the whole heart, and you're checking the whole heart in different section of the heart where all the valves are. You could do that also. Now, here's when we get to distal pulses, what we spoke about before. This number I need you to know, always a test question. If not class, the state. 60 to 100, better know that. Less than 60, bradycardia. More than 100, tachycardia. Know that. Know this. Pulse quality, always ask you this. Describe a stronger than normal pulse as bounded. A pulse that is weak and difficult to feel is weak or thready. Thready is known as weak and rapid. Okay, so know that just in case they ask you that. Regular and irregular, that's the rhythm. Remember, we always told you to give a rate, rhythm, and quality. That's what they taught you probably in skills when you did vital signs. Make sure you still do it that way. Blood pressure, systolic and diastolic. Everything you need to know of blood pressure is right here. Make sure you highlight that and you understand that. Continues. And then the BP cuff. And the gauge. And you do this. Now, I got a question for you here. You remember that arrow that you see here? There's always on your BP cuff, on the bladder area.
An artery.
There's
Artery.
the artery. What artery do you think they're talking about?
Brachial.
Brachial
Brachial.
artery.
So technically, that should be facing more this way where the brachial artery is. When you place your stethoscope, I guarantee some of you are still putting it right here in the middle. Right? Because you're taught that way. You're probably going right there, right? Right. See where you're doing, Isaiah? That's where you should put it, where that brachial artery is. So pick up your arms for a minute again, please, so they can see your massive bicep and tricep, okay? Okay, so let's go there. So don't be embarrassed. I'm going to utilize you. Okay. You see where his arm here, point right here for me, between your brachial, where your brachial artery. This is your bicep. This is your tricep, right in the middle, right? So if you know that if he follows this way, going towards the elbow, right? His stethoscope should be right here, not here, should be right here. So when you're listening for with your stethoscope and your patient's arm is out like this, okay, most of you put the stethoscope right here. You can still listen and hear it, but if you want good sound to really hear it, not here, go where the brachial arteries is and go right here, more medial. You follow me?
Mm-hmm.
That's the way you get a good sound. You're listening because you're following the brachial artery. It is not wrong being taught going straight in the middle. I'm just telling you that because that's what I see and how a lot of students say, well, Nuki, I need to hear it better. I can't hear it. What am I doing wrong? Maybe you're doing placement wrong. Okay? Are we confused with the difference with the words auscultating and palpation? Are you comfortable with that? One with the stethoscope, one without. Just making sure. And you're going to see skill drills in your book, 10-3 and 10-4. Look over that, read over that. This always the test questions right here. They say the adult systolic should be 90 to 130. That's what I see a lot in tests. Okay? They may put 120. So if they put 90 to 130, you're okay. So that means that top number should be 90 or higher when I'm doing a systolic. Okay? So know that to do with blood pressures. And then with neurological assessment, everything you're checking neurologically, they want you to look at the mental status, the dizziness, the drowsiness, that they pass out. And you do these two. Always test questions here. You know the APU already. You know this. What is the highest you could get on this?
15.
The number 15. What is the lowest?
3.
3. Always test questions. Okay. National Registry, we actually break each one down. And to know this, you need to know the other 3 letters. EVM stands for eyes, verbal response, motor response. Okay. So if they ask you, what does the classical coma scale consist of? Eyes, verbal response, motor response. You know this, and then I'll ask you what's the highest number you could get and the lowest number. The pupils always test questions. If I have constricted pupils, let's look at this. These, and these are dilated, and these are unequal. If I have constricted pupils, medical problem, tell me what I have. What could I have wrong? Constricted pupils, also known as pinpointed pupils or meiosis.
Drug overdose?
Drug overdose, excellent. Probably some kind of opiate or opioids. Someone else said something. What else?
No, I said cardiac arrest, but I was
No,
wrong.
not cardiac arrest. Good try, but no cigar. Okay.
Mm-mm.
So give me something else. I want you to think, medical wise.
Traumatic brain injury.
Brain injury, it is a possibility. Okay, but the brain injury, not really traumatic. What you're going to see here is a bleed in the pons. Okay, it's called a pontile bleed, will give you constricted pupils. Okay, that's medical wise. So it could be a form of bleed. If it's dilated pupils, what dilates the pupils? Think of things that when you check the pupil, it's fully dilated. They're on something. What?
Drugs.
Drugs. What type of drugs?
Methamphetamine.
Methamphetamines. Excellent. Jason, what did you say?
Stimulants.
Stimulants. Excellent. You're going to learn that in toxicology in your book. Think of everything that's upper stimulants, right? Cocaine, crack, methamphetamines, things like that, right? So how about this unequal pupils, also known as anisocoria?
Injury to one side of the head.
Yes, an injury, right? Severe head injury causing a form of intracranial pressure, ICP, unequal pupils, traumatic head injuries. Okay, what else would give you unequal pupils? Medical.
a brain aneurysm?
It's possible brain aneurysm. You're in the right category. What is that? What am I looking for? You're right.
Certain birth
Say that again,
uh,
Jason.
congenital
Something that's
disorders, diseases.
congenital. It could be cancerous, it could be congenital. Or how about a stroke?
Mm.
How about a stroke? Stroke is known for unequal pupils, right? So you need to know these things when you look at it. So these are the eyes. No, make sure you know the eyes. And these are all different types of depression brain functions. Brain stem, injury to the brain, trauma or stroke, brain tumor, inadequate oxygenation or perfusion, drugs or toxins. They tell you this to do with pupils. There goes the word anisocoria, unequal pupils. You always try to find pearl, right? You need to know the word pearls in your book. You check out the neurological status, you check everything, making sure that they got a post-motor sensory, upper extremity, lower extremities, right? You need to do that. You'll see a skill drill called 10-5 in your book. Make sure you look at that. You're going to see when you're going to be doing certain skills there that they want to make sure you're checking everything. So make sure you do that also. And let me see if I can find it for you. I'm trying to find it and I don't see it. It's skipping around on me. Okay. Skill drill 10-5, assessing neurovascular status. It's right under where it says the pearl, assessing neurovascular status. And you're going to see a skill drill there, palpating the radial pulses and the posterior tibial, dorsalis pedis. Look at that. It's very interesting to know these. Okay. Checking cap refill. You'll see all that there. How they extend the foot, how they bring it this way and that way. I use a mnemonic called TWERP, TWERP, especially for the lower extremities. Touch, wiggle, elevate, raise, push, and pull. That's Nuki, that's old school. And you're doing the same thing on these steps, similar of what the skill drill is trying to show you here. And then you check all your anatomical regions, the head to toe. You do that decap PTLS all over, okay? When you get to the abdominal sections, that's when you're going to do certain things different, and the chest. They should have showed you that in skills. If not, you will learn it. And you're inspecting and palpating everything. Okay, this is the head to toe, the chest. You're listening for lung sounds. You're doing the abdomen. Always a test question. When you need to know all four quads, if I complain of pain to my right lower quad, where would I begin first to palpate? I'm complaining on my right lower quad. I got a pain there, I'm telling you. I'm lying supine on the floor. Where will you start first? You would start in the right upper quad, then the left upper quad, then the left lower quad, and then you would leave for last the right lower quad. In other words, where the patient's telling you the pain is, you're not going to start there, okay? You would start away from that pain in a clockwise formation. So that's when you're doing this, okay? That's what you're going to be doing, checking up all the quads. Is there any one of you here confused with anything in the quads to do with the organs and certain conditions? Are you comfortable with all the organs?
Do you always start with the furthest quad and then go clockwise?
Yes. Wherever they're describing the pain at, you go past that. So if I say to you, Lewis, I have pain in my left lower quad, then you're going to start in the right lower quad, right upper quad, left upper quad, and then the left lower quad. And sometimes I won't even palpate that left lower quad, depending how bad is that pain. If I do, it's very gentle and soft, because I want to see how bad it's hurting them, because they're going to let you know it hurts, and you're looking for rebound tenderness and everything else. So book talks about clockwise. They should have taught you that in skills. When it comes to bookwise, it tells you clockwise formation. Good question. The pelvis, what you look for. If I say you're looking for bleeding and deformity in the pelvis, you go down, you go in and down. That's how they taught you, probably in and down, right? And then you look for the word incontinence or defecation and urination there, right? You want to see. You're looking for a neurological shock, priapism, right? You know what the priapism, that's that erection, because to do with a cervical injury, right? 3, 4, and 5 keeps you alive. So you need to know this. So that's a form of what we call neurogenic shock. So no words like that when you see it in the future. And then, of course, posterior, decap BTLS. Did you notice that each section here, you're doing a decap BTLS, but you're doing the hands-on, you're checking everything, head to toe, decap BTLS, every body part. So if I was doing trauma and Nuki was doing this, or if I was watching one of you, you would start with the head, and you will mention decap BTLS, decap BTLS, decap BTLS. A student asked me before, Nuki, is it better to verbalize everything, say and do? And I said, yeah, if you know everything. But if a good instructor is watching you and they see you inspecting and palpating everything, and you're just saying decap BTLS, they know exactly what you're looking for. Okay? Can you mention each one? I'm checking the frontal lobe, parietal lobe, occipital, temporal, the orbits, the nasal cavity, the zygomatic, the maxilla, the mandible, the cervical, blah, 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 decap BTLS. Yeah, I know. I know you're doing a good head to toe. That's what you have to do with decap BTLS. Make sure you know that. It's a complete head to toe. When you look in the ears, the eyes, the nose, and the mouth, they call it the 7 offices. Am I pronouncing it correctly? I'm getting tongue-tied here. But I always used to joke around with the students and said, the 7 holes, okay? And people say, what kind of holes? Holes like, openings, not the holes you're thinking about. So the eyes, 1, 2, 3, 4, 5, 6, 7. I don't care what order you give. 1, 2, 3, 4, 5, 6, 7. Right? When you look in the ears, what are you looking for? Or in the nose, what are you looking for? Cerebrospinal fluid coming down. If it's a severe head injury and trauma, ICP, intracranial pressure, you need to know these things when they ask you that. Okay? Okay, the pulse ox. We're almost done here. Any questions on the pulse ox? Okay, beautiful.
Does the pulse ox go on right away?
No, doesn't have to, Jason. You can't do it in your primary if you want to. You could do it under breathing or circulation, or you could use it in the future as your 6th vital sign when you're doing vitals. That is up to you. But if you have all these nice pieces of equipment that comes with inside your jump kit, your tech bag, then utilize them. Remember, don't treat that, treat the patient. Don't rely on these little so-called toys or pieces of equipment or tools. Treat the patient, but it's up to you. Can you use it ahead of time in your primary? The answer is yes. Do you have to? The answer is no. Can you wait for vitals? Yes. It's up to you. This one, I always talk about this because you need to know this. That blood glucometer, you're going to learn this in pharmacology. Make sure you play with this. You're going to finger stick each other in class, most likely, if they're still doing it. I think you learn a lot here. The BGL, the regular blood glucose level, is 80 to 120. You must know that. Test questions on the state, probably in class. Know that number. Anything past 120 is hyperglycemia. Okay, it's elevated. That sugar is real high. So it goes from like 120 to like maybe 400. Past 400, it gets into diabetic ketone acidosis. You're going to learn that when you get to, I think it's hematologic emergencies. Okay. And you're going to learn that later on. I think it's with the endocrine system. The blood pressure cuff, you went over in class. You know how to take a good set of vitals, systolic and diastolic, by auscultation and palpation. And the reassessment here, whatever they complained before, you're going to repeat everything. Repeat your primary, repeat any interventions, your transport, your general impression. You're repeating that all in your reassessment. Rechecking everything. Okay, this always test questions 5 and 15. Now we get into questions, and then we're going to look and make sure we touch base on everything. And then once this uploads, I will send you the link. You click on it, start documenting, and there's no way you should be ready for Tuesday's exam on patient assessment, because it's going to be everything to do with what we talked about. And we're going to double check everything. Okay, there's a question.
I have a question. I know you said that for the mechanism of injury, you have to do decap. But for nature of illness, what do you have to do where you don't have to do for like MRI? These are like things you have to do and things you don't have to do.
It's all the questions. So you will have to do whatever order you want to do it. You have to do vital signs. That's according to the state. And then you have to do the sample and the OPQR-STI. Those are all questions. Remember, medical is 80% questions, 20% hands-on. Trauma is the opposite. It's 80% hands-on, 20% questions. Okay? I send you this, Isaiah, look at it. Because once I get done here with you guys, I'm going to go to my phone and I'm going to send you everything that, according to Kenny, you didn't receive before. Remember, this is only a guide. Okay, these things you can easily download from the internet and YouTube and all this, even your state website. I just share this with the students to help you, but you'll see it. So look at that when I send it to you. Okay, did that help you a little bit between MOI and NOI? Beautiful.
Yeah,
so
thank you.
Get in B. Some of you put D. I want all what? It should have been B. During the scene size up, you should routinely determine all of the following except it's the ratio of pediatric patients to the adult patients. That's the except. If you read it like this, okay, and a lot of you should read it this way. During the scene size up, you should routinely determine all of the following. Put your finger on the except or your thumb, cover it, and then read that question and do it. Should you do A, the mechanism of injury or nature of illness? Yes. Okay. Should you do whether or not additional resources are needed? Yes, it makes sense. Is there any hazard? That's all done in the scene size up. You are not doing B. That's how you answer not and accept questions. There's a lot of not and accept questions on the state. You better get used to these. Components of the scene size up after standard precautions include determining the scene is safe for entry, determining the mechanism of injury or nature of illness, determine the number of patients, and determine additional resources are needed at the scene. Yes, they are sometimes. So if you tried the way I said it, watch this. This was the question. During the scene size up, you should routinely determine all of the following except. So put your finger on this. Read it again. During the scene size up, you should routinely determine all of the following. Then read it. Okay, the mechanism of injury, nature of illness, yeah, that's in the scene size up. Okay. B, the ratio of pediatric patients to adult patients? No, I don't remember that in the scene size up. So most likely you can say that's the answer, but then continue reading. Whether or not additional resources are needed, yeah, that's in the scene size up. If there's any hazards that jeopardize safety, that's in the scene size up. Think of what you said in the scene size up before. the state sheet, and what did I say? BSI, scene safety, number of patients, additional resources, MOI, NOI, C-spine. I said 6 things. Out of those 6 things I just said, which one makes the most sense that should not be there? And that's B. Try to practice, whoever's having problems with these type of questions, the not or accept question. Put your finger or your thumb on it and then read the question again and answer it that way and see what you come up with. I noticed that 99.9% of the time, you get it correctly that way. Okay, number 2. Okay, I got 2 people to answer so far. Okay. Not bad. You arrive at the scene of an injured person. As you exit the ambulance, you see a man lying on the floor, on the front porch of his house. He appears to have been shot in the head and is lying in a pool of blood. You should, what? Retreat to a safe place and wait for law enforcement. I'm not going in there. If I go to someone's front porch and they're shot in the head and I'm looking, I'm going to say, yeah, we're not going in there. Let's retreat. Let's back up. It's not abandonment. It's just my safety is first and my partner. You know, it's same safety. So that's the answer. It is D. Your primary responsibility as an EMT is protect yourself prior to entering any scene. You must assess the potential dangers. In cases where violence has occurred, you must retreat to a safe place and wait for law enforcement personnel to arrive. I always gave this one I did to students. You guys are located in 329 when you go to LaGuardia, right? The 3rd floor. Right when you open that door, it's the cafeteria, the entrance on the left side, right, of you. There's a door. If I walked to that door and I saw a bunch of people and I was with you, unconscious, foaming, fumes flying around there in that lunchroom area, and then foaming in the mouth and defecating all over themselves. Guess what Nuki's going to do? I'm going to back up. I'm going to close the doors. I'm going to say, do not enter. But Nuki, we could save them. No. But they may die. Okay, it's their time. Let's call 911 and do what we have to do. I know it's kind of funny. Nuki, you actually let them die? No, I don't want to, but scene safety. My safety, your safety, my partners, things like that. Are you following me? That's what I'm trying to make a point here with you guys. Next one. Number 3. Some of you answer these questions so quick. It's amazing. You read it and you just know. I like that. Findings such as inadequate breathing of an altered level of consciousness should be identified in what? And it's A, it's in your primary. Okay. A lot of this you'll find in your ABCs. The purpose of your primary assessment to identify and manage any life threats to the patient, such as inadequate breathing, altered level of consciousness, and severe hemorrhaging. You take care of that all in your primary, right? Let me make sure we did the other one before. And yes, we did. We went over that one. Just wanted to make sure. Okay, number 4, not questions. Try that with putting your finger on the not. Yeah. Okay.
Sorry, made a mistake.
It's okay. If you have to change it, you change it. But now you're getting the not. You put your finger on it. So you read it like this. Which of the following would you detect while determining your initial general impression of a patient? Will you detect probably cyanosis? That's possible, yes. Will you detect gurgling? Yes. Will you detect Severe bleeding? Yes. Will you detect a rapid heart rate? No, not in my general impression, really. So you go here, and that would be the not. So you go back and you see why. The initial general impression is what you first notice as you approach the patient, but before physical contact with that patient is made. It is what you see, hear, or smell. A rapid heart rate, tachycardia, would not be detected until you actually perform that entire primary assessment. You cannot see, hear, or smell tachycardia. So it's almost like you're thinking it's a quick tick, kind of tricky question or a trick question, but you got to read it a certain way. Number 5. Okay, I got like 3 of you, 4 of you. Excellent. Okay. We're going back and forth here a little bit, but mostly you are picking B. Your primary assessment of an elderly woman who fell reveals an altered level of consciousness and a large hematoma to her forehead. After protecting her spine and administer oxygen, you should, and the correct answer is perform a rapid assessment or rapid exam, and this is the reason why. If any life-threatening problems are discovered in the primary assessment, they should be addressed immediately, right? You know that something life-threatening supersedes the ABCD. The EMT should then perform a rapid exam to look for potential life-threatening injuries or conditions. That's why that answer is B. Reassess your interventions, this last step of the patient assessment process. Correct answer, transfer the patient immediately. This is determined after the completion of your rapid exam. Perform a focused assessment on the head. This is performed during the secondary assessment. So it's how they're asking you the questions. Number 6. Not bad. A lot of you put in the correct answer. A semi-conscious patient pushes your hand away when you pinch his earlobe. You should describe to his level of consciousness as, and the correct answer is C, responsive to painful stimuli. Semi-conscious patients are not alert, nor they are unresponsive. The fact that the patient pushes your hand away when you pinch his earlobe indicates that he is responsive to painful stimuli. If he opens his eyes or responds when you speak to him, he would be described as being responsive to verbal stimuli, Number 7. Getting a bunch of B's, I saw one C.
I was gonna go with B, but I'm gonna go with C.
B or C?
I'm gonna go with C.
Okay, the correct answer really here is B. Say why? Watch. Assessment of an unconscious patient, breathing begins by. You cannot assess or treat an unconscious patient breathing until their airway is patent. That is open and free of obstruction. Manual opening of the patient's airway, example, head tilt, chin lift, or jaw thrust. Use caution as needed to clear the airway or blood and other liquids. Insert an airway adjunct to assist in maintaining airway patency, and then assess the patient's respiratory effort. That's why when you went back here, assessment of an unconscious patient, breathing begins by, and you have to what? Manually position that head properly because you got to do airway, breathing, and then circulation.
Mhm. ABC.
And almost it's almost like it's tricky and confusing a little bit, but that's how they give you these questions that you got to be careful with. Okay, number 8. Some of you know this real quick. I see a lot of B's so far. Continue reading and feel comfortable. A 12-year-old patient can speak only 2 to 3 words without pausing to take a breath. He has a serious breathing problem known as, and that is B, 2 to 3 word dyspnea. 2 to 3 word dyspnea is a severe breathing problem in which a patient can speak only 2 to 3 words at a time without pausing to take a breath. Number 9. Excuse me. Instead of fish, I wish I had some lobster and shrimps. Or oysters or clams.
You're just going for all the recyclers of the trash in the sea, man.
Okay, all right. That's what God put it there for, puppy. It's all right. I can eat anything. I can eat eggs with I can eat worms with scrambled eggs. A lot of you are putting D and B. Okay, I got a few B's.
Unresponsive.
Okay. Let's look again. How should you determine the pulse in an unresponsive 8-year-old patient?
B.
And some of you put in B, palpate the brachial. No.
No.
That's
it's
less than
C.
1-year-old.
Thank you.
Oh, yes.
Do
It's
what
from
you
only
like.
1
You
to
see?
6, right?
No, 1 years old down is the brachial pulse,
1
right?
year old down.
Brachial
Oh,
artery, right?
okay.
If it's 1,
Unresponsive is carotid.
it's carotid, but it's still carotid if it's older than 1 year.
Yeah.
The brachial's only in infancy, 1 and down. Okay? I know. That one got you, John. I like the way you say, got me. It's true. Update the carotid pulse in the neck. Watch. In unresponsive patients older than 1 year, you should palpate the carotid pulse in the neck. If you cannot palpate a pulse in an unresponsive patient, begin CPR. Remember, no pulse, no breathing, CPR. Number 10. What? Not bad. When assessing your patient's pain, he says it started in his chest but has spread to his legs. This is an example of what part of the OPQRST mnemonic, okay? And it's C, radiation. You got to remember these words. And please know the difference between the word radiation and referred pain. Radiation, radiated pain, referred pain. What's the difference? A radiated pain, or the word radiation, is when, let's say if I have chest pains and is radiating, traveling to my arm or both my arms, my neck, my jaw, my back. That is called a radiate or radiation pain, radiating, traveling. If you see the word referred pain, that means you're having 2 pains at the same time. Got that? What do they mean? If I got pain to my right upper quad, and you know the organs are there, and I got another pain to my right shoulder, and they just finished eating spicy or fatty foods, what problems could occur with that? It's called cholecystitis. It's to do with the gallbladder. It's inflamed and so forth, okay? That is called referred pain, and then you know the difference between radiating pain. Make sure you know that when you see in your textbook. Over here, they have the regional radiation section of the OPQRST. Mnemonic assesses a patient's pain, where it hurts and where the pain has spread because of the patient informed you that the pain spread from the chest to his legs. This will be example of radiation. Okay. We are going to double check everything here, and then we will be done for the evening. Give me 1 minute.
Hmm.
It's bad when you have certain glasses and you only can see certain things. I'm blind as a bat. Give me 1 minute, please.
Don't worry, we're patient.
Thank you. I appreciate it, Maria. I'm trying to find the notes and I can't find it. I know I have it somewhere. Just bear with me. Oh boy. Maybe I thought I downloaded here and I didn't.
Yo, Kelly, how are you comfortable sitting like that, bro?
I don't know, to be honest.
Flexible people. That's a not over two problem or advantage.
The best I could do is Indian style, man. I can't do the knee, hugging my own knees. That's
I
crazy.
can't even do that.
You have to
Wait,
stretch.
how long can you
The
sit in
older
Indian
you
style?
get, you have to stretch. And now your muscles start to tense up. You have to stretch every day.
Just bear with me. I will find it. I know I have it somewhere. I just figure out where I downloaded it at. Nope. Wrong one. Okay, I think I found it. Let's make sure you all comfortable to do with your patient assessment? Is there any questions on signs and symptoms, MOI or NOI, index of suspicion, okay, chief complaint, OPQRST, sample, any of those that you're not sure with or familiar with that you need help? Okay, this is the time to ask to make sure you're comfortable with that. Okay, so you're good with that. If I don't hear nothing, so we know DCAP BTLS, we know the sample, we need the OPQRSTI, everything that represents that. That's awesome. Are you comfortable with words like scene size up, primary, HPI, which is history of present illness, or the sample portion, your secondary, which you do a bunch of stuff there, or you do the DCAP BTLS in your secondary to do with trauma. You need to know all that. Are you comfortable with blood pressures, the numbers? I'm talking blood pressures, systolic, diastolic, what they represent, pulses, rate,
Want me to put it up?
quality,
Sure.
okay?
It was just
Also, respirations, rate, rhythm, and quality, the skin, the CTC, okay? You need to know all this. The decision-making, everything there. Want to make sure. Are you comfortable with airway, breathing, and circulation, everything that contains in there, what you do? If I say in airway, what are you looking to do in airway? There's a mnemonic that we spoke about.
Open, clear, maintain.
Yeah, open, clear, maintain, and probably sounds, right?
Mhm.
If it's breathing, what mnemonic are you utilizing? Breathing.
Listen.
Oh, I pass.
Or I pass, right? Or I pass so, either one, right? Oxygen, inspect, palpate, auscultate, stabilize, and seal. If it's circulation, what are you looking for? On the circulation, you're in your primary. What do you look for there?
CTC.
Besides the CTC that falls in there, what is that?
VCR.
VCRs with the S at the end, or VCRs with an extra S, whatever, which way the instructor or instructors taught you. So that's good. You need to know that. So we're good with the ABC. We're good with HPI, history of present illness. What does it mean when you do vital signs? When they say you're taking a baseline, what do they mean by that?
The first set of vitals that you take.
Yes, the first set of vitals that you take, right? You need to know that. Make sure you understand that. That's excellent. Good. Are you comfortable with your GCS, Glasgow Coma Scale? Are you comfortable with the APU? Are you comfortable with all your quads? Oh, I got her. I'll take care of her. I got it, Maria. I already did it. I could do it on my side real quick. I ask you. So that we can hear the background, you know? Unless they're cooking for all of us right now. Right, Isaiah? We're like, okay, unless you're giving us food, okay, mute. I'm only joking. All right. Is there any questions to do with the patient assessment, like the chief complaint, your APU, anything like that, where you feel comfortable? If I mention the word pulse ox, what am I talking about?
Pulse oximetry.
Yes, excellent, John. Pulse oximetry to measure the oxygen saturation of the hemoglobin, right? You need to know all these, right? Maria, you put something there that I can't see, but or someone put it there. Maybe it's Jason.
That's me.
Oh, that's you?
I'm throwing the Glasgow Coma Scale. That's the ones I have written down. Like that's from the Wikipedia, so it shows all that stuff. It's important to know.
That is so cool. I'm just looking at it.
There's one for pediatric and one for adult.
That is so cool. I'm glad you put that there.
Nuki,
Yeah,
what does SIDS mean?
Sudden infant
What
death
is
syndrome.
Death syndrome.
it's Southern Infant Death Syndrome, right?
Okay.
Trust me, I've been there, done that. That's the most saddest calls you're gonna get in EMS. I had a 6-month-old Hispanic child. One of my first cardiac arrests was an infant. That's the saddest thing. I cried, especially after the call. I tried to do the best I can with the medics. I was an EMT at that time, and that was one of my first pediatric cardiac arrests. And you never forget it. I still remember the address: 633 Myrtle Avenue, top floor. You know that stood with you when you could remember 30 years later, right? That you're like, whoa. So it's calls like that. So yes, you'll know that. You'll see it. Are you comfortable with your scene size up, your primary? What needs to be there? What are you looking for? I need to make sure. Okay. Your ab pool. All your quads. We went over the eyes. We went over the pearl, constricted pupils, dilated pupils, everything. Are you comfortable how you take a blood pressure?
Mhm.
Okay, good. Do you know when and when not to take a blood pressure? Like if a person had a certain problem on the arm or in the breast area, did they ever teach that?
No, I got that wrong on the practice on REMT exam.
Okay. You need to know when there's a patient had like a maxectomy, you won't do it. If the patient is dialysis and they have a shunt on their arm, you won't take that blood pressure on that arm. Okay? The patient has an injury on that arm. So all those things, you don't do it. If it's nothing, everything is normal, that's where you take the blood pressure out. So think of maxectomy, think of shunts to do with dialysis, think of injured arm, okay? Things like that. You don't put and do a BP, the sphygmomanometer, BP cuff on that arm. If it's normal and they say do it in this arm, feel free. But everything else, you cannot do it. Just make sure you know that. Just want to make sure in case they didn't mention that to you. We did the OPQRSTI. You know that already. You know the decap BTLS. You know the pulse ox, right? You know when and when not to utilize the pulse ox, okay? You remember all the problems that a pulse ox would not give you correct numbers. Think of everything we spoke about. I think Kenny and John and Jason, some of you put carbon monoxide poisoning. You put hypovolemic shock, hypothermia, anemic, and nail polish, dark in color. Other words than that, know when you can or cannot put it also there. So make sure. Are we comfortable with post-motor sensory and all the pulses? If there's anyone here who's not sure what does a posterior tibial mean and where it's located, dorsalis pedis, radial pulses, carotid, femoral, brachial, okay, you need to know all those pulses. Okay. Cap refill, are you comfortable with CRT, capillary refill time? I'm not hearing nothing, so
That's 2 seconds, right?
2 seconds or less, John. Excellent.
Great.
Yes. Anything past that 2 seconds, they use the word, it's considered delayed. Okay, we did the ABCs already. Okay, systolic wise, what's my normal blood pressure systolic should be? What number to what number?
90 to 120.
It said 90 to 120. And I said, if you don't see that and you see 90 to 130, then that's your answer. Okay, it depends how they're going to ask you that. We know the sample, we already went over all that. We went over the OPQ STI. We know all the times of good perfusion to do with the brain, the lungs, the kidneys, and the musculoskeletal. Make sure you know those times, all those organs. Very important. Remember what is the most one with lack of that good perfusion? It's the skin. It's the musculoskeletal. That's up to 2 hours. Everything else, like the heart, the brain, and the lungs, need that good oxygenation, right? So make sure you know that. So it would shunt away from there and give it to them. You know the difference between the patient assessment, the full body scan. Remember, you know what you do. If I miss something in my primary, you could do it where? In your secondary. So make sure you know that, okay? We already went over this.
What's the difference between respiratory failure again and cardiac arrest?
Okay. I want you to know it this way, Kelly. Respiratory distress first. They're having a problem. No matter, it could be the rate, the quality of it, and so forth. Then they get into respiratory failure. So don't think that matters got worse. Whatever is the condition in the system, sign and symptom that's coming on. It could be asthmatic, COPD, whatever's going on here that's causing them to have that respiratory distress prior. Then they go into respiratory arrest. That means their breathing is inadequate or absent, no longer there. They have a pulse. It could be weak, but it's there. That's called respiratory arrest. That's when you're going to be utilizing the BVM. Can you utilize the BVM before that in respiratory failure? The answer is yes, depending what other signs and symptoms you see. So it goes respiratory distress, respiratory failure, respiratory arrest, cardiac arrest, no pulse, no breathing. Are you following me? Each one. Respiratory distress, respiratory failure, whatever the condition and everything that's going on with the signs and symptoms. Then they go into respiratory arrest. That means the breathing is inadequate or absent. Okay? It's not cardiac arrest yet. Cardiac arrest is the last one. That means there's no pulse, no breathing. You got that? That should answer the question you just asked to do with respiratory failure and respiratory distress. So far that I'm checking all my notes here that I see, we went over everything we needed to go over. BVM, O2, the OPA, when it should be used. We went over signs and symptoms. We talked about headaches and vomiting and all that other good stuff.
You had the last thing you mentioned was something about BGL. What was it again?
Oh, BGL stands for blood glucose levels.
Oh, blood glucose
That's
level.
when you're using the glucometer, and the number you should always have there is 80 to 120. That's the norm. I know because I'm diabetic, type 2. So I always monitor. A good BGL for Nuki is 80 to 120. Anything past 120 is considered hyperglycemic. Hyperglycemic.
Oh, I put hypo. You see, okay.
No.
I had to correct myself.
Hypo is less than 80.
Okay, so it's hyper. Okay.
Right. Hyper, more than 120. That means the sugar is very elevated. Hyper. Hypo, the sugar is very low, less than 80. So less than 50, they're going into what we call insulin shock, hypoglycemia. You're going to learn that when we get into diabetes.
That's a lot of fun, by the
all
way.
that. Say that again.
That's a lot
Annie?
of fun being on super low glucose.
Oh my God. For people who really go to that, it's dangerous, but it's a true emergency that you could take care of. We know.
Okay, how do you solve for hyperglycemia?
Say that again, Louis?
Or how do you treat hyperglycemia?
Only oxygen. Oxygen. They say when in doubt, give sugar in hyper. And if you're a good EMT and you know the signs and symptoms, why are you going to give more sugar when the sugar is elevated? Look for the other signs and symptoms, give them oxygen transport. They need definitive care. Not even me as a medic. I don't carry insulin on the ambulance. I cannot give them insulin to take care of a hyperglycemic patient. Hospital. You can only treat hypo with
If-
the glucose. Remember that.
let's say a diabetic, their blood glucose is 300 and they currently take Fiasp. Are we allowed to are we allowed to administer that with
Nope.
to a system?
Nope.
No. Okay.
No. You're going over your scope of training.
Okay.
Right? You know what they call a scope of practice. What you learn as an EMT or as a paramedic, you go by that. Sometimes you're going to be so upset that you got this unconscious patient and you're only could do and give them oxygen, and you know they're diabetic, but you cannot put the oral glucose in there because they can't swallow or drink on their own. So all you could do is transport. The best thing you could do is call for medics and rendezvous with them, or not straight to the hospital. So yeah, you wish you could do certain things. Until they say we could do certain skills, you can't. You're above your scope of practice. You can't do it. I don't want you to get in trouble and lose your job. Otherwise than that, we're good. We went over everything. I'm looking at all my notes. You are good to go here. Everything we covered that's in this video, which I'm going to pause the video now or stop it so we can upload.
Recording stopped.